call our board retreat meeting to order. We have five board members here with 3 absent. And first item on the agenda is, I'm sorry.
Health insurance claims update.
Yes, health insurance claims update. Lengthy agenda item.
Mr. President, before we get started, could I just briefly introduce our Ed Rising students this morning? These are students that are currently in Educators Rising. These are potential teachers. Some of them plan to be teachers, so thank you for joining us. There will be a group this morning. They do have to leave at 9 o'clock because of a pep rally at one of our schools, but they want to learn more about what takes place with our Board of Education and these types of meetings.
Can they introduce themselves?
Yeah, absolutely.
So
Ms.
come up.
Fitzgerald, can you have them come up to introduce themselves and where they're from?
Just say just come up like right at the corner there. Just say their name and what they, like, what level or what they plan on, what they want to teach, think they want to teach.
Good morning.
I should have got it.
We'll go down the line. I'll ask them to tell their names and what school they're going to.
My name is Brody LeBlanc, and I go to Destiny.
What do you plan on teaching?
I would like to teach high school theater.
Now remember, not all of them, they're exploring teaching, so some of them may not actually want to teach. Of course, we want them all to be teachers, but, okay, yeah.
Hi, my name is Fabiana Martinez Gonzalez, and I go to Destiny High School, and I want to be a trafficologist. Cool. My name is Lucy Desai, I want to teach lower elementary. I'm Master Garage, I go to Hondell, and I also want to teach lower elementary. I'm Lily Martinez, I go to Hondell. I'm Sophia Siker, I go to Destiny, and I want to teach like pre-K. I'm Tori Miet, I go to Hondell, and I want to teach kindergarten. I'm Natalia Lemus, I go to Destrehan, and I want to teach high school English. I'm Jillian Kaz, I go to Hornville High School, and I want to teach younger elementaries.
I'm Peyton Bouvier and I go to Hornville and I want to teach history.
I'm Layla Brown, I go to Hornville, and I want to be a process tech.
I'm Blakely Thompson, I go to Homedale, and I want to teach 2nd and 3rd grade.
Thank you for coming, and look, this program is not only grown, upper 40, almost 50 numbers than last year was, and I can tell you, take advantage of everything that's available to you. My daughter was in this class last year, and she's now a freshman at Southeastern to be a teacher, and she's enjoying the heck out of it, so appreciate you.
Thank you.
And you know what parish to come back to when you become a teacher. Thank you.
Thank you, thank you.
Okay, Mr. President, we have, Ms. Darrenisha Gales is out of the country, which is why she is not here. So we do have Ms. Samantha Burris, who will facilitate part of this agenda item, of course, with members of USI, and I'll allow them to introduce themselves. But Ms. Burris, if you want to, and she's our insurance technician in the Insurance and Benefits Department. Ms. Burris?
Thank you, Dr. Ortland. So good morning. My name is Samantha Burris. I'm the insurance technician for St. Charles Parish Public Schools. On behalf of Ms. Gales and myself, we would like to thank you for your time this morning. First, I will provide a risk management and benefits department update. Then I will transition the floor to USI and UMR, who will provide a presentation on health insurance claims. So as you know, St. Charles Parish Public Schools became self-insured for medical insurance in year 2022 with Humana. Humana dropped out of the group health insurance in year 2023, and then St. Charles Parish Public Schools transitioned to UMR effective May 1st, 2024. So the first years of becoming self-insured were really learning years for our department. Now that we're moving beyond the initial phase, Ms. Gales and I are researching and developing next steps to successfully improve our self-insured health fund. And the department update that I will share to you today is a glimpse into our initiatives that will align with our long-range strategic action plan. So the topics that I will discuss will include organizations that we are a member of, which is the Society of Human Resource Management, or SHRM, the Employer Coalition. I will provide information on high-cost claims initiative, as well as the medical claims audit. One of the organizations that we are a member of is the Society of Human Resource Management. Ms. Gales and I are both SHRM certified, and we attended the National SHRM Conference in July. At this conference, we gained critical insights on current benefit trends, benefit compliance, and best practices. At the conference, there was a strong emphasis on mental health and the importance of boosting the employee assistance program that we have, as mental health and behavioral claims are increasing and on the rise. So with this information in mind, our department is engaging ways to communicate the employee assistance program. Some of the methods that we are utilizing is we've discussed the employee assistance program at the beginning of the year meetings. We have posters printed to display at various sites, and we include this information on the monthly Health Matters newsletter. Another organization that we are a member of is the Employer Coalition of Louisiana. This coalition consists of mainly self-funded employers across the state, so this gives us a unique opportunity to network with other self-insured employers. The coalition is dedicated to increasing the value of healthcare by lowering costs and improving quality and consumer experience. The coalition hosts various events throughout the year that brings pertinent subject matter experts to provide valuable insights and relevant healthcare information. One of the events that was recently hosted by the coalition was a high-cost claims workshop, which I will discuss on the next slide. Ms. Gales and I attended this high-cost claims workshop, and we gained valuable insights on high-cost claims trends and drivers of high-cost claims, which USI and UMR will go into more detail about that data. And we learned about the type of data we should be requesting and analyzing in order to address and forecast our high-cost claims. And just to give you an idea of numbers, high-cost claims accounted for 37.8% of our total plan spend last year, which accounted for a total cost of $11.4 million. So there really is a need to look at this data so that we can address high-cost claims and forecasts. Yes, ma'am. High-cost claims accounted for 37.8% of the total plan spend for our last plan year, which accounted for $11.4 million. And USI and UMR will go into more detail of what that data looks like.
And just for reference, 2017, I believe our total cost premium-wise was $17 million. So that puts it in obviously we're over $30 million now, but when you consider where we were, I mean, obviously it's relative, especially when you talk about increased costs, but obviously targeting our high-cost claims should be a significant effort of ours in our department.
2017
I think it was either 17 or 13, don't quote me, but it started off about $17 million total for the entire health insurance premium package for us that the district was paying.
Thank you, Dr. Ortling.
Yep.
So with the information that we learned at this high-cost claims event, some of the next steps that Ms. Gales and I are partaking in, we're requesting more data, we're looking at more data, we've increased communications with our broker and TPA and PBM, holding more frequent meetings with them, and Ms. Gales is developing next steps in our long-range strategic action plan that will be presented in the future. And the last thing I would like to discuss is the UMR medical claims audit that's currently being conducted. The medical claims audit has been a previous agenda item that's been approved. The reason we're doing it, haven't done it sooner, is we switched carriers and TPAs. Now that we have a full plan year of data, we can now do the audit. This will be a random audit where 250 claims will be selected to audit. BMI is the vendor for this audit. They utilize a stratified random sampling to select the claims, so they will actually be selecting the claims to audit. The preliminary steps have been completed, so we've completed the service agreement, the client success plan. So now BMI is requesting the data, and they will actually conduct the audit. The time frame for this audit is 5 to 7 months, so we have an estimated completion time of April of 2026. And of course, when this audit is completed, we will report to the board the findings of this audit. Okay, so this concludes the department update presentation. Again, this is a glimpse into the initiatives that Ms. Gales and I are partaking in. Thank you for your time. Are there any questions specifically about the department updates?
You mentioned the coalition.
Yes, sir.
Do you have other school districts that are part of the coalition?
There is another school district, yes, sir. And then also there are other, there are private sector employers as well. So, yes. Thank you for that question.
The audit, you said 250 claims or 250 people?
Claims, 250 medical claims, yes, sir.
Okay. Do they try and select, I'm just curious, do they, the claims, like, do they select the same person? You know what I mean? Like, so somebody's gonna have multiple claims, right? So we just select the same person?
So they have, so they utilize a
Unless that's
stratified random sampling. They have a certain mechanism that they use to select the claim. So it's not specifically the same person, it's just based on how they, their mechanism to select the
Certain
claims.
size claims, small, big?
They try to select from a wide range.
Wide range. Okay.
Yes, sir.
Gotcha. Thank you.
Thank you for your question.
You know, as we get ready to transition it to UMR and USI, I just want to, commend Ms. Burris, Ms. Gales. When we took, when the board decided after very long discussions, obviously with USI and the planning moving forward to go self-insured, we knew that would come with changes to that department. We've added, with the support of the board, relative to adding additional support, in fact, Ms. Burris's position, right? Those changes have allowed us to look at this with a little bit more detail. But at the same time, I think, referring back to what Ms. Burris started with, we're still growing in this field. So I do appreciate, the focus on continuous improvement to save the district money relative to health insurance, because this is our plan. While we obviously have long appreciated the support and continue to lean on USI and now UMR, ultimately it's our responsibility to dig into and make sure that we're providing a checks and balances as much as USI and UMR. So there are going to be additional, as you saw in the beginning of the presentation, with them being part of these organizations that help build the capacity of people who run self-insured programs. Medical insurance, as we all know, very complicated, right? Very costly, right? It is a significant part of our operating budget. So to me, having the resources available and the internal competencies is important. And I think moving forward, you'll see a continued growth in that area, and I appreciate the attentiveness of that, but also realize this is our plan, right? We can't just rely on other outside agencies just to be the only ones that carry that forward. So certainly, I think you'll continue to see our growth in that area, specifically to help, us curb costs relative to health insurance.
And I think we understood when we made a decision to go self-funded, there was no going back. We were going to be doing this for the foreseeable future. So
Yes, sir.
It is just to echo what you, it is a good
How long-
focus.
How long we been self-funded?
This is
Since
our
2022.
third year. This is our third year, Ms. Beck. We talked about it for about 20 probably.
Yeah.
So, okay, Ms. Burris?
Thank you, Dr. Ortling.
Yep.
So next, I would like to introduce representatives that we have here with us. So from USI, we have David Babin, the Employee Benefits Broker, Jesse Babin, Senior Vice President of Employee Benefits, Nora Roulet, Senior Account Executive. From UMR, we have Darlene Sins, Senior Strategic Account Executive. We have Sam Atkinson, Care Consultant. Heather Steele, Strategic Account Executive with OptumRx. And we have Shelby Conway, the Director of Account Management. So with this, I'd like to transition the floor over to them, and they will provide a presentation on health insurance claims. There you go, Darlene. Thank you.
Thanks, Samantha. I'll just quickly open up before we turn it over to UMR. Appreciate the opportunity to speak this morning. You know, the presentation today, I'd say we really have two goals. First goal is to do a deep dive into claims analysis from our full first plan year with UMR. That started May of 2024 through April of 2025. This claims data is more of an FYI. As Samantha had mentioned, you know, we use this data to help strategize in upcoming renewal, whether there's any plan design changes or program strategy changes that need to take place. And in upcoming board meetings, USI will be meeting in front of you soon to talk more of the financial side of how we ended up last plan year with UMR than this current plan year. So that's going to be coming up more from the financial perspective. And then kind of the second goal here is to talk about our care management programs that are in place. You know, it's important to keep in mind that when we talk about claims, there's a person behind that, whether it's an employee or a dependent. And when somebody's diagnosed with a serious condition, we want to make sure that you know that there's support from healthcare professionals to help them navigate the healthcare market that can be extremely complex and confusing, to make sure they're right care at the right time. So again, we're going to do a deep dive into medical and pharmacy claims from this past plan year, and then talk about our care management programs that we have in place to support our employees and members when they need to utilize the care. So, and then also we're going to address today the LCMC situation and negotiations, and what we know at this point. UMR is going to address that at the end. So with that, I'll turn it over to Darlene, and she's going to dive right into the presentation.
Thanks, David. So thank you for allowing us to come out and meet with you today. We, in addition to all of the reports that are available on demand for USI and the school system, we have a data analytics team that really gets into the meat and behind the scenes of what your claims are. So if we're seeing an uptick in something, we can drill down and see more information about where it's coming from, who it is, the providers, and so forth. So we're real excited to come out and give this presentation to our customers, especially you guys on year one. If you look at the criteria to table set what we're going to show you today, it's your plan year May 24 through April 30th. So any claim that happened during that time, and we allow a 3-month window for those claims to clear up. And so we have a very good picture of your plan. Going forward, we'll have prior year data to share. But since we don't have that, and I know USI does, you know, a historical look for you, we're focusing on your plan and how you compare to the norm and your peers. So on the right-hand side, you can see the norm is all of the UMR groups that represent about 7.8 million members across the country. And then for today, we're using groups of your size, not necessarily education, but of your size. We are looking at flipping to an education peer going forward, but for today, we're really talking about the norm anyway, okay? So the executive summary, this is just meant to highlight what we're going to talk about today. Your membership is pretty much broken out between subscribers. So a subscriber is an employee or a retiree. Dependents is everybody who falls under there. So you're kind of split 50-50 almost between those two categories. Your demographic factor, and this is why to keep in the back that we're talking about our norm, which is the 7.8 million, your demographic factor is 1.08. A demographic factor looks at the age, the gender, the family size of your population. If a norm is 1, which that's what we use, if the norm is 1, we would anticipate your claims to be 8% higher than the norm, just based on your membership, okay? In the middle column, we'll talk about cost drivers, and again, you're running about 10.5% higher than the norm. You had a couple of high-cost claimants that may be driving that, and we'll discuss that. But the real direction of your claims is coming from those that are non-high-cost claimants. So you can see below that your non-high-cost claimants, that's the HCC, and I didn't say this earlier, high-cost claimants for this exhibit is anybody who has $50,000 in claims combined with medical and pharmacy. Okay, so it's not your stop loss or anything. This is just the number we use in our report. Your high-cost claimants are running less than the norm, but your non-high-cost claimants are running higher. So the goal is to keep them from converting to high-cost claimants. The 3 top diagnostic pay categories are listed below, and we're going to talk about those as we go further in. Your benefit package is very important to your employees. And if you look at the 2 circles at the bottom on the left-hand side, it shows, because our norm is about 75% of the members using their benefits. At St. Charles Parish Schools, almost 89% of members are using their benefits. That's one of the highest numbers I have in my groups. So it's why people come to work here, young people. On the right-hand side, you'll see the medical network utilization. Your members have access. About 99% of them are using network providers. And then a key is that 88% of them are actually seeing a primary care physician. And that's going to be important as we get a little further on. So your cost trends, you're at, for medical, you're at $651 per member per month, combined medical and pharmacy. And again, that's above the peer and the norm. And we're not going to, I wanted to tell you that as we grow, so you'll have a 2024, a 2025, 2026. We can add up to 4 or 5 years here, so we'll be able to help build that story, the same one that USI is building with you guys on a regular basis. The bottom graph divides how those dollars are spent up for medical. So inpatient is dark blue, outpatient is green, physician is the darker blue. But most importantly, if you look at the right-hand side, this is where the dollars are going. So you have less spend on inpatient admissions and a higher spend than the norm on outpatient surgeries. That's not necessarily a bad thing that it's higher, because we would prefer people to be at an outpatient facility rather than inpatient. Your ER visits are higher than the norm, as well as office visits. So let's dig into some of this data. From a diagnostic cost drivers, these are the top 5 categories. 53% of your medical spend is coming from these 5 categories. So health status and services, that is all the wellness visits. That's your routine visits that your members are seeking, as well as things like chemotherapy. And those are broken down on the far right-hand side with the actual spend. Health status is number 1 here, and it's number 1 for the norm. That's a good thing. You then move into musculoskeletal, which is pretty standard in this area. And then we have injury and poisoning, which is number 3 for you and number 6 in the norm. Injury and poisoning are things like sprains, strains, infections, and complications from surgeries. So that is something. You've got some sepsis, which was one of the things that Ms. Burris showed up here. So on the right-hand side, it breaks down more of the details of each category if you'd like further information on that. Then your high-cost claimants, and again, 50,000 medical and pharmacy. There were 104 people that fell into this bucket. That's about a little less than 3% of your population, but as Ms. Burris said, it's almost 38% of your spend. So it's real important that we address those members throughout our how we manage your plan. Right underneath in the left-hand side, it tells you how the members are broken out. 71% are actually your employees or your retirees. So of the 104 high-cost claimants, 74 are either an employee or a retiree. 85% of them are currently active on the plan. And then the next 3 lines are important as we go forward. Can't wait to come next year, as you can tell, because next year we'll be able to see who was in the plan last year versus the current year. Were they a high-cost claimant last year? Are they a high-cost claimant this year? So those next 3 lines will be building upon those. And then if you look at the bottom right-hand side, you can see the top diagnostic groupings for your high-cost claimants. Number one was live born. You had a set of twins that were higher costs, about almost $460,000 paid last year. So they were a main cost driver. And then the next category, which I struggle with saying, but it's back, spine, joint, those kind of things. The next one is chemotherapy, and then you get into cerebral vascular disease, osteoarthritis, and then finally septic situations. Okay? On the cost trend side, we showed that the emergency room visits were about almost 17% higher than the norm, so we thought it was important to share this with you guys. We want you, I think David said it, we want people to get care at the right place at the right time. So is an emergency room the place to be for everything? And when we're digging into this, we look at potentially avoidable emergency room visits. So if you look at the bottom right-hand side, that's things like back pain, infections, upper respiratory, stomach issues, things that maybe could be treated. And I say maybe because it's not always the case, but it's a potential. In those situations, we'd prefer them to go to an urgent care or use Teladoc, which is available. In this case, the reason is, you see the check mark in the bottom, a potentially avoidable ER visit costs $1,588 more than an urgent care visit. And that's on your pay. You know, that's what the school system is paying. So we would always want to try to shift people, when appropriate, to other avenues of care. And the chart at the bottom, your visits per patient, and this is another key driver here, 34 patients went to the ER more than 4 times. One person went 11 times. Yeah, so it's something that we want to look at, and behind the scenes, we can look at those people and see, was it an appropriate use going 11 times? Are they in case management? And we do that.
Darlene, I'm gonna stop you right there, and open it up for any questions or concerns that you, guys have at this time regarding the information she presented thus far.
11 times.
It happens. We see that sometimes.
When you say emergency room visit, and maybe this is if it's in the weeds, we'll get it later. So for example, let me use St. John Parish, where we don't have that hospital. The Ochsner has that little outfit, for those of y'all know, it's right near Belterre and Airline. I think they call it like their mini emergency. I don't know what the actual name of it is. Is that considered emergency room?
Yeah, they bill like an emergency room.
So they bill like an emergency room.
It's like a freestanding emergency room, emergency services.
Interesting.
Yeah.
But I wonder if that, I mean, I don't know. I wonder if that's why, I'm just curious. What happens is they don't have a hospital, but they'll go there, they'll get them stabilized or whatever we call it, and then get them, I don't know.
We'll definitely look into that,
I'm
Mr.
just curious.
Gregson, and report back to you.
I mean, I'm not familiar with St. John specifically, but I know, I mean, personally, even down I-10, I see individual ER facilities popping up. They look like an urgent care, but it's not.
So that's, and that kind of was going to my question, I guess, if that's how they bill.
So my question is, okay, obviously this is UMR's first year, but David, this really question is for you. Like, where are the comparable stats for ER visits from our previous plans compared to how they are now? I think that, to me, is more valuable. While this is all relevant information, but I'd like to know where we have been to where we are now.
And we can also look at the top facilities to see where they're going for care, and then potentially where the alternatives are, whether there's alternate urgent care opportunities available in those areas, and then, certainly even help with some education campaign for redirection.
Because we have certainly, I think, and Samantha could probably answer that, but we have tried to message that. We're directing our employees, obviously, by the PCP, by the amount, the percentage that are going to their PCP, which is great. But that statistic really that stands out to me. So I'd really like to know where we were previously.
Well, I think one of the things too is we can look at plan costs, okay? And it's relatively
compared to $150. So someone says, you know, I'm gonna just pay $150 and go to the emergency room and skip urgent care, the line might be too long. So I mean, I think
Yeah.
maybe with David, then we need to look at the cost we're charging. And look, if it's an emergency, it's an emergency, you go to emergency, I'm not, you know,
Right.
but, I think that's one thing we can look at to possibly, help our people in the plan choose urgent care over, the emergency rooms.
Yeah, two things. First, our USI report will show previous into Humana, so we can compare year over year. This is more of our plan year with UMR. But also, we will use this to determine whether or not it makes sense to raise our emergency room. The benefit to kind of deter if you have the sniffles or some type of ailment that you could see urgent care for, you can utilize that.
And thank you for bringing up that point, Mr. Oakland, and we will certainly look into that at, February meetings is when we really look into recommendations and things like that.
Look, if you have a chest pain, go to emergency room, you don't go to urgent.
Right.
Because you got, like Dave, you got sniffles, you know.
Yeah, and I think it's like 250.
I think that's right.
It's 150.
It's different on different
Depends on the
plans.
Yeah, it depends on what plan.
Depends on
you're
the plan.
I think to the point, what the 150, 250, whatever, the question goes back to how they, like, if we look at just region-wide, the kind of the parishes where most of our people live, right? I mean, don't get, who, like, the Jefferson, St. Charles, maybe St. John, I don't, wherever they live, those facilities, to his point about up and down I-10, what are they billing as? Because, and the reason because my other hat is, I've had this conversation where we got somebody that wants a hospital in St. John, but yet we have this outfit, but heck, it doesn't matter, they bill the same.
Right.
It's not billing as urgent care, they're billing the hospital, so.
And I'm wondering too, how many of you use an ambulance to go to the emergency room? Like they're actually calling 911. And I think what we might need to do for y'all as well, like give people a health matter steps. Call your primary care, call the emergency room, call these things and give you guidance, because they might be able to do something over the phone before you hit that emergency room. But I'm like everybody else, an emergency is an emergency, but I would like to know how many of them were actually picked up by ambulance
Okay.
and brought to the emergency room.
Yes, ma'am, we will definitely get that
In
information
comparison
for you.
to the ones that just drove there with a spouse or another person.
Right.
We can also break it down by facility to see where employees are going, what facilities they're using, emergency room, et cetera.
Because I just don't know how they bill. I think that's an interesting point you brought up, because, I see the same thing you brought up.
Right.
And as I mentioned, it can be perceived as an urgent care if it's just a freestanding facility.
That's my point.
Right.
Yeah.
That's where.
It says emergency on it, but most freestanding facilities traditionally have been urgent care centers. Now they're built as emergency.
And that's where I was going, because I brought specifically the one up there because they don't have the hospital anymore, so they brought, and my understanding from those folks is that facility got filled up quick.
And you know what, break it down by members are dependent. Because if you have a baby, and the baby's having trouble breathing from being sick, I promise you, I'm going to the emergency room, I'm not gonna be going to urgent care or whatever, So I would like to see those numbers as well, because it might be more, when you talk about somebody with 10 or more visits, it could be someone with a chronic, illness, maybe going through cancer treatment and struggling, so, it's, before we go, 11 visits.
We can drill down on that.
We don't know how serious the illness could be.
Right.
Right.
Drill down on that.
11 times $250.
Thank you
We've
all
seen more.
for your questions. And we will certainly report back to that.
Yeah. And
Right,
just
monthly
before I
visit.
go to the next slide, potentially avoidable, just remember that is, we understand if I've got a baby
Right.
or
Right, I
that
know
situation.
that,
This
yeah.
is just, this is a stepping point for conversations that will be happening
Right.
in the near
Right.
future.
And
So,
I appreciate
yeah,
that.
thank you.
And even
Yeah.
one of the
Yes.
earlier slides, you talked about
Those are
you're
the
gonna have, and then young women,
Good point.
Right,
and young
correct.
women have babies.
Yes.
So it kind of goes hand in hand, you know?
And to your
Yes,
point,
they do.
they will actually,
We're aware.
That's correct.
yeah.
We have plenty of babies.
They do.
And later on down the slides, we'll see that information being brought up as well regarding, demographics and things
They're
like
not
that.
gonna have to be teachers with babies.
Yes,
Exactly, exactly. So this, the next slide is about wellness and prevention, and the fact that your employees and their dependents are using the benefits to the level that we saw on an earlier slide. This is great because in every category, in year one, which, we have to build up some data because we get, as we go forward, your members are ahead of the norm in every single category. Well visits, mammograms, cervical cancer, colorectal, and cholesterol screenings. And why is that important? On the right-hand side, a member with an annual physical has a higher percentage of getting screenings. So we talk about the ladies. A lady who has a physical is 47% higher chance of getting a mammogram. And a mammogram identifying breast cancer early keeps your costs from going up. So that's important. Because we only had the 1 year of data, I just put all of the diagnostic breakouts on one slide for you just to see where your money is going. We talked about musculoskeletal. We're going to talk about metabolic conditions in a second, type 2 diabetes. You're really higher than the norm in everything except cancer. And I am not a medical professional, but I would suggest that possibly because your screenings are so high, you're catching things earlier. So that's a good thing, because in this market, cancer is never lower than the norm on any of my groups. So that's a good thing. And your behavioral health spend is lower than the norm, which probably goes to the EAP utilization as well. So your metabolic conditions, these are the ones that become ongoing long-term potential spend, high dollar spend. You're spending about $14.5 million on metabolic conditions. And if you look at the chart at the bottom, what's a metabolic condition? First, I have obesity, hypertension, or high cholesterol. That's preliminary. When I cross over to have 2 or all 3 of those, then I'm truly a metabolic condition. Diabetes only, and you're higher than the norm here, but that's being in the South, we have learned. Diabetes plus, one of the other categories, and then coronary artery disease and congestive heart failure. These are the people that we need to impact early on through care programs and so forth to keep them from progressing to the next stage. And you guys teed up this maternity slide for us. You actually had, if you look in the middle, you had 41 babies in the 12 months during this reporting period. It is higher than the norm, but the norm is all commercial business, not just school systems. You have a higher, only slightly higher than the norm, set of employees between 20 and 44, which is that normal childbearing years. And then the bottom right-hand side does show that your average cost of childbirth is higher, but that may be skewed just a little bit because of the claims you've had. So that's important.
So this is including the high-cost claims, so like those twins?
Yes, yes. And last for me is your network performance. So we did talk in the beginning, I said that 99% of your claims are going through network providers. We're very happy about that. You're getting a 66% discount on those claims. And then the 59% overall discount, that includes the network claims, out-of-network claims, coordination of benefit claims, when you combine everything, you're still at almost 60% from a discount perspective. So I was
Can you
gonna-
kind of explain, what do you mean when you say discount perspective? Like, what does that represent?
Yeah, that represents the allowed charge versus versus the bill charges or the contracted rate. So round figures, if the charge that a hospital has for a procedure is $100, and we're paying, they've agreed to accept 40, that's a 60% discount. It's round math.
I understand.
Okay, yeah.
So, and those are sorry, but I think it's
No, that's
important for
fine.
us to have and for the board to understand. So that is based on the contracts that we have with said
Right.
provider, correct?
Yes.
So for Ochsner, we've negotiated relative to what the actual cost would be for our employees based on our plan to attend those
Yes.
hospitals or whatever provider.
I guess that's part when you get your explanation of benefits, it will show that, you know, the visit was $482, but the plan paid $100, and that's what they have to accept because of the contract.
Yes, yes. And that's a good point. I was going to bring up EOB because it doesn't always show a member EOB may not show the true discount because sometimes they will bill the actual contracted amount. We're seeing that some. So you may see a number that looks like a 2% discount, but that's not true. It's just that the billed amount is representative of maybe a closer to contracted amount. But yeah, and it's important for a member to review an EOB before they pay a claim. Because there's always, remember I mentioned earlier, the COB, the coordination of benefits. If there's any question about how a claim processes, there's a note on that explanation of benefit that gives them, we need accident information if it was a motor vehicle accident. We need other insurance information, maybe if you're a dependent, to make sure that your employer doesn't have coverage. So that's always a key thing to look at in claims. Okay?
Yeah, and I'll just quickly note, just kind of to the superintendent's point, you know, United has one of the best network discounts in our market, one. And then two, as we design the Ochsner-driven program, you know, that's a high-performing network. So the outcomes, percentage-wise, are better. That's why we're driving in that plan our employees to the Ochsner network. And then also, you know, we have protections in place in our program that drive our members to centers of excellence, especially for our transplant conditions. And I don't want to get into Sam's talk here, but that's kind of just high level, some protections we have in place here. Kind of circles all the way back to Samantha's introduction, talking about high claimants and what are we doing to control these costs. It's making sure we have, you know, a proper network in place to get them taken care of in and get them out faster, as low cost as possible.
Okay. Before we turn it over to Sam, are there any other questions before he takes a dive into care programs? Go right. Do we have any information? That's something that we can, what specific information would you?
On all of the information that you're providing us,
Mhm.
do you have, comparing us to a school?
I got that one. Yeah.
That's
Not just an employee, it could be,
Yeah.
you know, it could be a company that has 75% men instead of 75% female.
Right, right. Going forward, we will use the peer, you know, we said the norm, which is all of our book of business. When we get down to the peer level, we can do education. So we'll pull in universities and school systems across the country.
You have that?
We don't have that today, no,
But we can.
but we can.
And we will as we get more data through the
Yes.
second year.
Thank you, Mr. Alexander.
Yep. Sam?
Yeah, so David actually made a great segue into what we're going to talk about with these next couple pages. So what I'm going to talk about specifically is the care management programs that y'all have in place today. you're gonna see on these next couple slides, you're gonna see CARE listed on each one, and it's really an acronym that we go by. It stands for Clinical Advocacy, Relationships to Empower. It's really our mission statement. The goal within CARE is to essentially have a clinical management program in place for any member, no matter where they fall on that healthcare spectrum. It can be the healthy member who just wants to engage with the clinician, to the complex, very catastrophic members, such as a transplant who needs a high level of clinical support. So as you can see on this page, we have the kind of this CARE umbrella that branches off into a bunch of different care programs. The ones that are highlighted in dark blue are the programs that you guys have in place today. So utilization management, that's the prior authorization process. That's the program we have in place to ensure treatment and procedures are medically necessary before the health plan actually pays for them. We use the United Healthcare Clinical Guidelines to determine the medical necessity of those procedures. Complex condition care, that's better known as case management. So when you think of case management, it's really the highest level of care that UMR offers. So it's for your transplant patients, chemotherapies, traumatic brain injuries, spinal cord injuries, very catastrophic, potentially very expensive patients that fall into that category. Ongoing condition care, that's disease management. So when you think of ongoing condition care, you think chronic conditions like diabetes and asthma, COPD, coronary artery disease, and things like that. We want to engage those members in this program to make sure that they understand how to, really properly manage that condition. Maternity care is another program that you have in place today. The name of the program kind of says it all. It is, it's there to help support the mom that's just learned that they're pregnant, or maybe a female that's planning to become pregnant. You also have Care Queues. Care Queues it's a program that happens in the background automatically. It's UMR's digital solution to closing open gaps in care. So there's 150 gaps in care that it's looking for, and when it finds an open gap in care, UMR reaches out to that member and kind of holds their hand while they close that gap in care. And lastly, the CARE app is it's an app in itself, and it's really a clinical focused app, and the reason for the app is to really enhance the experience that the member has with the nurse that they're working with. So I wanted to give just a quick brief overview of the programs you have in place. Go ahead.
Mr. Oakland?
I'm not sure, but doesn't the district pay for the Ochsner digital medicine program? Is that coordinated with this, or is that something that's overlapped? I mean,
So that's separate. That's
so
separate.
are we paying for something that do we really need to be paying for?
Great point, and we're having those conversations right now with Teresa and that team that's been coordinating with Ochsner. So we had Ochsner in place before we moved on board with UMR, and it was a 3-year contract, and it's actually up right now. We've been kind of comparing and contrasting both programs to see if it makes sense to continue with Ochsner, because it is separate from UMR.
And,
question.
and Sam, can you speak to, so we know the highlighted items that are in blue are what we currently have. Can you speak to why we don't have the others, and the dark ones are what's included in our agreement? So the others would be a charge, correct?
Right.
Yes.
Yeah, and so to that point, we have other programs, emerging care and persistent back and neck pain, those programs that are in the light blue. These programs will come into play throughout, as we gain more claims data and we have a better idea of how the plan's running year to year. It's a conversation that we can have to kind of strategize and get a better understanding of what additional programs we can put in place to affect those claims. And also support those members who those claims are tied to.
I think if you go back to the data, like the persistent back and neck pain, that wouldn't follow any of your musculoskeletal.
It might,
Yeah,
so that Yeah, we need to, that's part of what we're doing with the risk management team in USI is looking at the claims data, seeing if the program is truly a good fit or were there some outliers in those claims. So if there were outliers in the claims, maybe you don't add a program that isn't, you're not gonna get the bang for the buck. You know, we want you, if you're going to add programs, we want it to impact your overall plan. So we showed these here because we want you to be aware.
Just as Becky pointed to, the nurse line and nurse chat could help us with the urgent care and emergency room where someone can call first aid and say, where should I go? You know, and they'll tell you, hey, you need to do
100%.
emergency, or no, you know,
They have
just go see urgent care, they're gonna give you some antibiotics and you'll be fine.
Yeah.
So,
Yeah, and that's the reason we would probably, when we review that one, you have Teladoc. Teladoc allows 24 access to a physician, and that physician can actually prescribe, you know, antibiotics and rash creams and things like that, or say you really need to go to the emergency room.
Is that when we use Teladoc, is that charged, or is it part of the program?
It's a claim charge, and the member, I believe, is it free or is it a $10 copay? I
They
don't
do
know.
have a copay, it's associated on the type of plan that
Yeah.
they're in, so either the base high or HMO.
Yeah.
And do our employees know?
Mhm.
I mean,
Yeah, we have,
do people
Yeah.
do
we
a
have,
job of getting everything?
we have communicated it. I know it's been on the Health Matters quite a bit.
And letters get sent
yeah.
specifically
Yes.
about care
Correct.
and Teladoc.
Yes.
And the
I mean,
beginning,
letters
at
all
the
time.
beginning of the year meetings, we also informed employees of the Teladoc as well.
Yeah,
Yes,
so
sir.
we need to really push that.
And it's like anything else, you know, as we've kind of shifted our focus on primary care physicians, you see more and more going now, and that's reflected in this report. But I think as they become more aware of Teladoc and as more people continue to use it, then I think it should naturally increase. But I think our continued focus on making sure we're providing that information to our employees is important.
Okay, flip to the next page. So on the next page, we're looking at the 4 programs that you have in place today. And this page specifically digs into some more detail as to how members are engaging in each program. So let's start at utilization management, which is the prior authorization process. This isn't necessarily a program that the member has a choice in, right? This is typically between the provider and UMR. The provider, you know, let's say the patient has a procedure coming up and the provider needs to get prior authorization for that service. So they submit the prior authorization to UMR. UMR uses those United Healthcare clinical guidelines to review for the medical necessity and issue approval or denial. In this case specifically, almost 75% of every prior authorization that's been submitted is approved. So very, very good numbers. And it's telling us that majority of those providers who are submitting the authorizations, they understand the United Healthcare clinical guideline and they're following those guidelines before the authorization is submitted. If we jump down to complex condition care, this is case management. I could go on and on about this program because I get a little passionate about it because I see it on a daily basis how it can affect members that are engaged and how it truly affects them. So again, this is for the very complex treatment plans, transplants, chemos, things like that. You have almost a 60% engagement rate in this program. And when I say that's phenomenal, it's an understatement. And it's to the point to where the school board itself has become kind of a poster child within the care department at UMR because the engagement in this program is so good. So just, again, really, really impressive. And before I move on, I want to say the true importance of this program and how it can affect the patient is that, you know, when you think of the worst case scenarios, like a complex chemo treatment plan or a transplant or a traumatic brain injury where the patient can't move, they have a lot of care happening, right? They're in a lot of different facilities and they have a lot of different physicians. They have a lot of claims coming in, and sometimes these claims are super expensive, and maybe they have to go through multiple levels of review, and it can be a overwhelming feeling for the member themselves. So having a case manager and having that direct contact and direct support for that member or that member's family is, it's just an absolute game changer for that patient's care plan. And I see it on a daily basis, and I see how it can truly affect these members in a positive fashion. So seeing seeing 58.3% engagement rate in this program is absolutely phenomenal. So looking at maternity care, so this program in itself, I mean, it's kind of twofold. You know, you want to have this program in place as a great benefit for the female population. You know, whether they're a first-time mom and they want additional clinical support through a maternity care program, but you also want to have this program in place as almost a safety blanket. And what I mean by that is one of the main focuses in this program is to identify, based off of claims data, high-risk pregnancies. So we're going to use our analytical claim software to look at this claims to see, okay, which members are pregnant and do they have a comorbidity tied to that pregnancy? Do they have preeclampsia or anxiety or depression? And having the maternity care program in place to manage the high-risk pregnancies to ultimately, you know, support that member to deliver a healthy baby is really what this program is about. I know historically, and we've talked about this in the past, the school board has had fantastic participation in a maternity management program. So while, you know, we had 93 members who were identified for this program and 8 members engaged, there was that transition period between, you know, coming from Humana to UMR. So as claims were coming in, by the time our maternity program was reaching out to those members, the timeline may not have lined up, so they didn't engage. All that being said, we've talked about this, I mean, on and on in the past, and I think we're going to be very pleasantly surprised to see the engagement rate in this program specifically increase a lot by the time we have second year claims data coming.
And to piggyback on what Sam is saying, we are having conversations on strategies, discussions to boost engagement in this program because due to our demographics, we're always going to have, you know, babies, right. You know. So we are having discussions to strategize ways to boost engagement in this program.
And maternity care is going to definitely be a big focus, but it's really all the programs. We're going to talk about complex condition care. We're going to talk about ongoing condition care, even utilization management, so members are aware of what a prior authorization is. So lastly, I want to talk about ongoing condition care. Like I mentioned before, this is disease management. So the way this program works is you have a low risk. When you look at chronic conditions like diabetes, you have a low-risk population, those members who do have that diagnosis, but they take their medications on time and they're seeing all the providers they need to see. But then you have your moderate risk population, maybe those members who aren't taking their medication on you know, they're not filling their medication every single month. But then we have our high-risk population who have a diabetes, for example, diagnosis, and they're not doing anything. They're not taking their medication, they're not seeing their doctors, they're just living with their condition and hoping for the best. Ongoing condition care is looking at those moderate risk and high risk individuals because we know that those are the members that we're going to have the biggest clinical impact on. The low risk, they're healthy. I mean, all things considered, they're healthy, they're managing their condition properly. It's the high risk and moderate risk that ongoing condition care is really going to impact. And the ultimate goal here with ongoing condition care is to engage those members and work with them on a monthly basis and make sure that they're managing their condition properly and they're identifying any open gaps in care that they have and they're closing those gaps in care. So the ongoing condition care nurse really becomes an extension of the member's provider team and helps them identify those gaps and close those gaps by taking their medication on a regular basis, or seeing their podiatrist on a regular basis, or whatever it may be. I'm gonna brag on y'all again, the 36% engagement rates for this program specifically is one of the best ones I've seen. So, again, just, I mean, and it's kind of a direct impact too on Samantha and Darrenisha and the HR team and David and his team to just get the word out there and make sure that members on the health plan are aware that these programs are available.
From that perspective, just because I know it was just mentioned about the Ochsner, you know, that pretty much kind of falls into that. I know, but currently, when you come up with this percentage participation, UMR is specifically looking at whether or not prescription medication is being refilled, they're going to doctor visits, not necessarily the direct, you know, because I know through the Ochsner program, we have close to 100% participation. I mean, we have tremendous participation in the digital, whatever, the blood pressure machines and everything else. So that's not taking that into consideration, and is that part of the condition care program that you all provide as a service? Can you kind of, how do those two things, I guess, mesh?
What we're looking at today, these numbers are totally separate from the Ochsner Digital Medicine Program. The overlap in the services that are being provided are similar.
Okay.
And because of that, I think that's why we've been having these discussions over the past couple of months to say, okay, what does this program offer? What does this program offer? And what can we do to make sure that we're consolidating these and not confusing the member?
And in reality, if for those participants of the Ochsner Digital Medicine, they're probably not having a gap in care, so we wouldn't identify them to do outreach. You know, if they're getting their medicines and they're seeing their doctors and they're participating in that program. So I think that's why it's a bigger discussion, you know, today, but it's important. You know, Sam says we brag on you guys, but it's true, your numbers are high, even knowing that that is behind the scenes.
Yeah, and I'll just kind of piggyback that as well. So those numbers don't take that into account, and the Ochsner program, as long as you're diagnosed as a diabetic, we're paying a monthly fee on that individual, where the ongoing condition care is really reaching out for an uncontrolled situation, more or less.
Okay.
So the cost doesn't incur on the UMR program unless we have an uncontrolled individual. In addition to that, the only additional cost is if someone does have a glucose monitor, then it's like $140 per glucose monitor. With the Ochsner Digital Program, we're paying them, it's $55 for a single condition, hypertension or diabetes, $75 if you have both of them. It includes a monitor, but we're paying $600 on average for a single condition for someone that may be controlled. There is a significant cost difference between the two programs, and we've laid that out to HR, and we presented that, and I think it'd be important to revisit that to see, because it is somewhat overlapping, and those that are participating in the Ochsner program would likely roll over into the care management program.
Yeah, and they've alluded to, but obviously, I know Ms. Brown, right, oversees that portion, right, the benefits portion, so as we move towards February, March, when we talk about plans and that contract expiring, that is what we'll bring back to the board relative to what that decision.
So is there any additional questions before I hand it off to Heather? On the right-hand side of the page, unique members are the individual members who are engaged in care. So you see 943 unique care identified members, meaning that's the number of members who, through claims data and prior authorizations, were identified as qualifying for one of these programs.
And I think when it talks about the unique member, meaning there could be a member who was in case management, but maybe also is identified as, you know, maybe a pregnant mother in the maternity care program, or potentially someone with hypertension. So they can be in more than one program, but 943 unique members participate across the programs, right?
Yeah, it's not counting twice.
You just said it better than
Right,
I
right.
It's not counting twice, it's just,
Yeah.
like, it's not counting them.
Yeah. Okay.
Good to move on to pharmacy? Okay. All right. So this first page has a lot of information on it. We'll probably spend a good amount of time. We're just going to go over very high-level planned paid information. We'll talk about traditional drugs, specialty drugs, and where you fall against the norm. Again, for this, for purposes of this discussion, we're just using our book of business norm for UMR. And then I'll get into talk a little bit about rebates and how those are offsetting some of your pharmacy spend. But just to start, on a whole, you have a pharmacy spend of $224.54 per member per month, and that's across all members. When we look at, it looks at about 10.4 million over the 12-month period that we're looking at, same as Darlene's May 2024 through, April 2025. When we break that down a little bit, the total spend exactly is $10,371,715. You're about half and half spent with your specialty and your traditional medications. So traditional medications, that's going to be the next column down. Those are your medications that treat diabetes, high blood pressure, kind of a lot of your chronic illnesses that have been around for a long time. They have, a lot of them have generics available. Those are going to fall to the traditional drug spend. And for that, that's where about 51% of your pharmacy dollars are going. For that, we have just about a $5.3 million spend over that 12-month period. And for your specialty medications, these are your medications where a lot of them are self-injectable that you'll go pick up at the pharmacy. Maybe the manufacturer has a coupon to lower the member pocket cost for them. They would treat mostly things like inflammatory conditions. If you have, rheumatoid arthritis, psoriasis, that is a very big umbrella. When we're talking about specialty drugs, inflammatory conditions, they can treat anything, like I said, from arthritis to irritable bowel disease, things like that, anything that's an inflammation. So when we're looking at those, we have a spend of 49%, just slightly over $5 million over the course of the year for those specialty drugs. Something interesting about that, I just wanted to point out, you have 79 members that are using specialty drugs that accounts, it's about 2.3% of your population, and that accounts for your 49% specialty spend. So you have, that's pretty normal. A very small percent of the population has a large part of the spend.
So, obviously, y'all don't have the historical perspective with us, but we've looked at relative to the prescription medication and the onset of, those medications that fall on the lines of treating diabetes as well as weight loss, and depending on how they're classified, does that fall under this specialty category?
Those would fall, you're talking about the injectable GLP-1 medications, Ozempic and Mounjaro.
Yes,
Those
ma'am.
would actually fall under the traditional medications.
Okay, traditional.
Yes.
Okay. So then, for the specialty ones here, those are necessary, so it's not like they're cheap, because I think the discussion has been with those, like, what we're considering GLP-1?
GLP-1.
Okay, GLP-1s, that's where we've kind of been talking about where we need to curb.
Yeah, we moved away from the more expensive ones, I think, to the traditional.
Yes, sir. So from this category, then those are necessary medications prescribed. It's not like they're choosing something that That they don't, I shouldn't say that. It's not that
Correct.
they're being selected to use it for a different purpose, is what I'm,
Right.
what
They're
I'm
typically
asking.
Some
have-
examples of those
Yeah.
special.
Sure, yeah. You know, there was a lot of talk, or there maybe still is a lot of talk about, you know, somebody maybe using Ozempic for weight loss. That doesn't happen under this plan.
Right.
There are
I think he's,
mechanisms in
I'm
place.
sorry, but I think he's asking for examples under this, your specialty
Falls into
policy.
specialty.
What are some examples?
Yes.
Oh, some examples
Sorry,
of
I didn't
specialty
mean-
policy. Sure, yeah, that would be maybe Humira, Stelara, Skyrizi, Tremfya, Taltz, all of those that you typically will see commercials on during your, you know, your programs during the week. Those are going to be your specialty drugs.
And those treat like inflammatory
Correct.
skin conditions,
Yep.
things like that.
Yep, inflammatory
Yeah, I
skin
don't,
conditions.
okay, you and Sherry can go sing the commercial.
I just think it's hilarious now that I
My
know
wife
about
sings
this, it's like-
commercials, but it's weird. Anyway, y'all can play it back if you want. What do those things do? I'm the least medical person there is, so I don't
The
watch it.
inflammatory drugs?
No, are they all inflammatory drugs?
Not for the majority
Right.
of your specialty drugs. They do treat inflammatory conditions.
Okay, I got you.
Yeah.
So our spend in the specialty area is pretty normal.
It is pretty normal, yep. It is about average. You're actually maybe a little bit under the norm. Our norm is about 52 to 54% specialty spend, where y'all are at 49% for the first year. Yeah, you're right about there.
And we do have some additional
I do.
slides
Yep,
to show that.
yep. Yep.
And then regionally,
There you go.
I know if you got on specialty drugs, they went through so many other things
Mhm.
before they got to that.
Yes.
Because the condition was not getting better.
Mhm.
So, you know, it's a path, and I'm glad we're under, but also I'm glad to know that we're able to help somebody with that kind of chronic condition. And you go through that, you know, and you find a medication that helps. That's very important, because then that means they're gonna come to work.
Right.
You know, and that's gonna get cost saving for us as well.
It's unfortunate that the price that the pharmaceutical companies charge for these medications until the patent runs out. And then once the patent runs out,
Yeah.
they buy, and the price is significant. I mean, they take advantage of us
Right.
during the time that they can
Yeah.
until the patent runs out, and then once that occurs, it's free game.
And I'll talk a little bit about that when we talk about, I just wanted to mention biosimilars a little bit later when we talk about some of those specialty drugs. But that is related to what you had just mentioned. The last thing I'm going to go over on this page, I don't know how to move it up.
I think it's cut off when it displays. So
Oh,
we
okay.
gave you a handout because we weren't sure that it would be perfect.
No.
But there's a bottom graph on this page that's not showing.
Yes, this is.
I don't, can I move it up? I don't want to press a button and make it go away.
We got it now.
Okay.
It's the bottom.
Make it go,
That's
I'll
good.
break it.
Or this right here.
Yes, yes, ma'am. Okay, perfect.
We got it. We don't need it.
Yep. And just to talk a little bit about rebates, there is, you know, for those of you that may
No.
not be aware, oh.
No, it's
No,
Nope.
No,
I think it just got cut off.
Kelsey.
We haven't.
Yeah.
Kelsey.
We're good, we're good. Yep.
Yeah, we're good.
Thank you.
Cut off here.
Now just need to cut.
So when we do have
Sorry.
those high-cost drugs, the pharmaceutical manufacturers do provide rebates.
There you go.
For some of, when some of those drugs are purchased. So that rebate is then sent back to, you know, back to the plan every quarter, and it will help to offset some of those laid out costs for those higher cost drugs. So when we're looking here, originally, prior to rebates being applied, the plan paid per member per month is $224.54. The rebates you received for this 12-month period offset that cost by just over 32%. So when we look at net of rebates, we are looking at plan paid per month of $150.14. About a 30% reduction that the plan is getting back from those rebates. And then we have, total is about 3.1 million, and I just had a breakout here for what rebates are coming back from traditional and specialty.
David, that's higher than it has been, right? Rebates previously were about
Yes.
$2 million, now it's an additional $1 million.
Mainly around our specialty spend.
So are our costs for prescription.
Yeah.
Just for an information purpose, so help me understand, because rebates in general, okay, so rebates for prescription medication, I'm assuming these companies, right, the prescription pharmacies provide rebates so that you are attracted, I guess, to use their medications. So does that, from a pharmacy standpoint or pharmacy plan, that's how those things are negotiated on into determining which medications in part are provided, like every year, right? We go through this whole process of determining what medications. Is that in the formula to help provide the rationale for the prescription medication?
It is.
Okay.
It is part of the formulary design, is that we look at, of course, we want to make sure that there is coverage, that there is a medication available to treat a condition. In most cases, there are often several. But what we will do, particularly when we're looking at the specialty drugs, we will look at what is the lowest net cost for the plan to pay to treat this condition. So, and I'll just jump to it right now. I think it's a good segue. If we can, I'm going to go to, I'm going to go to the page that says top 20 drugs. It's page 6 at the bottom. I don't know what I'm doing. Oh, okay. Thank you. Nope, keep going.
Top 20 drugs.
It's the third page from the back.
Yeah. Okay, so when we look here, those that are marked in gray, those are the specialty drugs. So when we look at these top 20 drugs, this is by plan paid. So this is what the board is paying out for these drugs. And you can see number 1 is Stelara. That is a specialty drug used to treat inflammatory conditions. Same with number 3 and number 5. You can see for the most part, all of the majority of the specialty drugs on this top 20 list are to treat those inflammatory conditions. There are some outliers with oncology, cystic fibrosis, and some for hematology as well. But when we're talking about lowest net cost for the plan and how we decide, what's going to be part of how we decide what's going to be on the formulary, when we're looking at Stelara and Humira particularly, we did have last year, I think about midway through last year, we did have what we call biosimilars. So it's a little bit different from a generic alternative. In the same vein, though, they are drugs that are made to work in a very similar fashion, and they still fall under the specialty and the inflammatory condition disease states and categories. So those biosimilars, members started taking those. We required members to move to those biosimilars, and the biosimilar for Stelara is Wezlana. The biosimilar for Humira is Amgevita. So we required, and it's not, the information is not going to show here because the requirement to change occurred on July 1st. Okay, so when we look at year-over-year information, we'll see some biosimilar information, but the costs are lower for Wezlana and Amgevita with the very similar clinical outcomes than Stelara and Humira.
Can you speak to about how much lower the costs will be?
It depends on the medication and the dosage. On average, it's about $500 to $600 less per fill. which, might not seem like a whole lot when you're, paying $27,000 per fill, but if you're looking at 8 members taking 50 prescriptions at a savings of $600, it adds up. And then the increased rebates also help to offset those costs, also. Any questions on that?
Tell me about the price on number one.
Stelara?
Yeah,
Okay.
you go across to the $29.34. What is that
That is per member per month.
per member per
Yep.
month?
Yep, so across, and that is across the entire population. So if, even if you, maybe a member isn't taking Stelara, part of your per member per month cost is $29 is going towards the cost of Stelara.
Okay, and the plan paid 1,300,000.
Yep, 1.3 million, that is a total plan paid for that.
Okay, so all the way on the end, 27,103. What is that number?
That is plan paid per fill, like per prescription.
It's 27,000 per script.
It is.
So if a doctor prescribes Stelara, every time you fill it, it's 27,000 to the plan. To the member, it's their member responsibility, it's either copay or percentage of it.
It was filled 50 times at the 27,000, so that's where you got the 1.3 million.
The $29 is in order to stack rank the drugs across the board. We take the total cost of the 1.3 and divide it by every member, so the 3,800 members. So you can then see on a per member per month basis how these drugs rank. So you'll see the second one, the Mounjaro is $25, but the plan's paying $1,100. The 1,100 versus the 27,000, that's a big difference, but the volume is there with the 1.1 million. So that's why we drill it down to per member per month.
Yeah, you got a lot more scripts.
Right. Yeah, correct.
What date frame is this May to?
May through April.
May 24 through April 30 of 25.
So May 24th?
May
May
1st of
1st,
2024 through April 30th of 2025. It's a one full plan year, our first full plan year we use.
I don't know if it was partial or not.
Yeah, full plan year.
So that's, excuse me, to Mr. Ellis's point, I guess, that it's 8 people, utilizers, with a total of 50, so it's, okay.
Any other questions on this or biosimilars?
And just to make sure I understand, the the number at the bottom of the total, 6.8 million, that, which represents the total amount that the plan paid out.
Correct.
And
For
that,
These
On the-
top
on the
20
top
drugs.
on these 20, on this page,
Yes.
and that represents a total, that's 66% of the total prescriptions paid on the plan.
That is correct.
Yes.
Yes.
So we're dealing with the 80, 20, 30 then, okay. Pretty much.
Yeah, and that's before rebates.
Right. When you, when
Kind of,
you're
yeah,
looking
I
at-
figured that, yeah.
All these numbers are, with exception to the rebate, that they're all prior to.
Now, well, I guess that's and if I'm jumping ahead, just
No, go ahead.
wait, but the rebates typically given on these, or are they given on after their 10 years is up? It's usually on the,
On usage.
Right.
On the script.
on the
these
one,
drugs
on
you
these,
see. Yes, each
the more
individual-
expensive ones.
Correct,
Yes.
yeah, each individual script has its own rebate
Right.
amount, yep.
Yep.
Okay.
Also, I don't know, but when we were in before we went self-insured, those rebates.
We didn't
went
get
to
it.
the-
Correct, we didn't get
We
it.
didn't get it.
That's right.
Went to the
That's one of
carrier.
reasons
Right.
we kind of went to self-insured, that we would get the rebates, not Humana or you got, whoever you
Approximately, and I don't know if we know this number, no, I can get it later. Approximately how much do we get in rebates during this time frame? Do we know?
3.1 million.
Of the 3.1 million total, not just
Total.
on these?
Total.
Total. Yep.
I'm still not straight.
Okay.
Okay, on number one, still there.
Mhm.
Underutilized, that's 8 people,
Correct.
and they get 50 pills,
50 prescriptions were
50
filled.
prescriptions.
Yes.
So, okay, and that's a year's worth, it's 27,000.
Correct. No,
No.
each script is
Per-
27,000. Right.
That's half a year, 27,000.
No,
No,
that's 1 month.
That's per prescription.
In 1 month, 1 script, 1 28-day
That's one script.
supply is
One
20.
script, but it's 50 pills.
No. Okay, so utilizers, we have 8 individual members taking the medication.
Okay,
In total, the medication was filled 50 times
50 times.
over this time period, and then per fill, you're paying $27,000.
So Ms. Ellis, let's say I'm one individual, a member, and I had a script filled 12 times in a 12-month period.
Yeah,
I would
every
be
month.
one utilizer, and then I had 12 of those 50, which would be scripts filled.
Yeah, went to the pharmacy 12 times.
So in total, you had 8 people use 50 scripts,
Okay,
50 fills.
So if you multiply 27,103 times the 50, you get 1,350,000.
okay, I
Right.
understand that part, but if it's 8 utilized, how many prescriptions are filled in 1 year?
Of this medication, there were 50.
There were 50.
50 for each?
No.
No.
We don't
Just in
have it
total.
broken down per utilizer.
Yeah.
So
Per
it averages,
You could have one user getting 3 prescriptions a year, you could have another user getting 12 prescriptions a year. The total of the
Number
8
of
is
prescriptions
50.
a year is 50.
The total of the
Total.
8
For they,
Yeah.
Okay, but you only have 8.
8 people,
Right.
that's correct.
so on average, each one of them was averaging
Like
what,
6.25.
6.25, 6.3.
Somebody might take it once every 2 months.
Right.
Somebody might take it once a month.
Exactly.
And it's not it's an injection.
Yeah.
So,
Depends on the doctor.
Correct.
Yeah.
but each time that injection takes place, it's $27,000.
Okay, whatever it is, I don't know if it's an injection or a
Right.
pill. Okay, 27,000.
And for the sake of time, Ms. Steele is gonna.
$55,000 for a year. If you have 8 people, you divide 50 by 8, it's gonna be like 6. So it's
6.25.
gonna be
Yes.
like two prescriptions per person.
No.
Or 2 injections.
No, it's 6, so if you take the 8 people divided by 50, the average is 6.25 per person. So they're getting 6.25 prescriptions a year, average, which is whatever.
About
About
120,000
120,000 per person.
$140,000.
It's about $170,000 for average, per the 8,
Right.
if you want to run that.
Just trying to get
Yeah, it's a lot. Go ahead, I'm sorry.
And Mr. Alexander, we can speak afterwards too, and just to make sure you fully understand as well. So if you want to speak after, I'm happy to. Thank you. For the sake of time, Ms. Steele is going to wrap up, and then Ms. Conway is going to give an update on the LCMC and UMR contract negotiations.
Just a quick overview. Again, I knew I was going to spend a lot of time just on these specialty and this overall cost for the plan pays. Does anybody have any questions about anything pharmacy related before?
The next page, catastrophic cases,
Okay.
top 20 plaintiffs. Can you give just an overview of
Yeah, absolutely.
like
So
what I'm looking at?
Key statistics, what page is that?
The very second to
the
last.
The very next page,
Okay.
page 8 or something.
Yes. So these are similar to what Darlene had for her catastrophic cases. These are members that have over $50 in pharmacy spend. The top drug for each condition is listed. The plan paid for each unique member is listed. And of course, whether they're employee or dependent is also here, the number of scripts they got. So just looking at number one again, we're looking at somebody who is taking Stelara. They are an employee. They filled 11 Stelara prescriptions during this time.
That would be a... No. We're good.
Okay.
This is Raptor working.
This is Raptor. That's our internal, remember how we said all of our employees have this downloaded also? So if there's a lockdown somewhere, you'll get a notification. So wherever you are, if somebody hits accidentally, we're finding out some buttons that, we'll get certain notifications.
Well, we'd rather be safe than sorry.
Yeah, we're good. So we're good.
So I guess the question on this, kind of alluding back to the previous page, when we look at the 6.8 million and how it represents 66%, just as, I guess I'm not surprised by it, but and I guess I could just sit here and do the math. Do we know what that kind of represents as a whole?
I can add it out.
We can get it later if you want to give it to them.
Yeah, I can add it out. Yeah.
I'm just curious, kind of like when we look at the top 20 represents 66%, what is you have the top 20 here, what's the top 20 or top 50 maybe represent as a whole of our entire spend? Just, I don't know what we do with the data, but I'm just curious, I guess.
One other thing, just kind of along with, obviously, I think, looking at the numbers, seeing the cost of these medications, are they within that whole, 7-year period where nobody can touch the
patent.
Yeah, the patent piece, right? That whole piece. Like, why are these drugs that expensive? And if there's a competitive market to come up with is it during that time period, which is why we have to deal with these prices relative to?
Yep.
Okay. That's why they make the commercials.
And that's why in the rebate part, that's what I was asking earlier, the rebate part comes from these.
Yeah.
They make it while they can, and
I know,
that's it.
I know.
Yeah.
There's only one
Yeah,
manufacturer
Stelara,
that can
Humira,
make
the
the
two
drug,
that
so
are coming off patent.
they have carte blanche to
Came off
charge.
patent.
I mean, that's,
Did, that's how the
Yeah,
biosimilar
you'll see
came
that,
out.
yeah, you should see
Alright.
impact on that.
We hear about health costs in other countries being a fraction of what we pay here. Are these other countries using these same drugs?
Some are.
Why is it so inexpensive other places?
Yeah, I honestly couldn't say. It's just, I think probably the different rules about surrounding,
Okay.
medications and pricing.
And I hear rumors that a doctor gets a percentage of a prescription. Is that true?
I think sometimes that happens, like they may get like a per script, I don't know what I'm gonna call it, a finder's fee, but essentially incentive. So if they are writing a script for,
absolutely.
But we don't pay
But by
that.
the
we don't pay
pharmaceutical
that,
company,
no,
not.
the manufacturer pays that.
Yeah, right.
You don't pay that, you don't
But
pay
the
that.
doctors, yeah.
The manufacturer pays it.
So there is truth.
There is
Maybe
truth to
there was
that,
some
yes.
legislation around it, but I don't know. We can look that up
So
though.
for the people I know in the pharmaceutical sales business, they push their drugs on doctors, and they incentivize the doctors by having them speak at their conference in Hawaii, and bring your family, and so they don't directly pay them, but they incentivize
In a roundabout
them
way.
to help them prescribe the medications that they're pushing. So that's how it's explained to me.
That sounds accurate.
And Ms. Steele mentioned the biosimilars for Stelara and Humira, effective July 1, so we'll see.
Decrease.
Yes, we'll see a decrease in that.
Thank you, appreciate that.
Turn turn over to Shelby now.
All right, negotiations, let's hear it.
All right, I'm going to provide you guys with a little bit of an update on our negotiations with LCMC Health. Certainly, I know that that's something that has been very much highly publicized in our market and then New Orleans market, and is of concern to our clients and our members as well. And I do want to start by reassuring you that we are certainly doing everything that we possibly can to come to an agreement with LCMC Health and continue to have them in our network without interruption. Our contract does expire on 11/1. The good news is that both parties are actively engaged in negotiations, so sometimes these kind of come to a stop at some point, and to date, both parties are still at the table and both actively negotiating. So again, LCMC Health is an important partner and important provider to us in the market, and we're going to continue those negotiations and continue to try to compromise to an extent so that we can reimburse them at a market competitive rate, but also being financially responsible at a rate that is continues to balance the access of our members and employers like you to affordable health care. The last proposal that they delivered to us is still a little high and still a little far off. It would increase overall healthcare costs in the market by $113 million, 80 million of which would be absorbed by our self-funded customers and clients like you. So in trying to protect that, we're going to continue to stay at the table, continue to negotiate, continue to be financially responsible about that, but understanding, the compromise and that they're a very important provider in our market.
So, Ms. Burris, just to you, because I know this was brought up, right, with Ms. Gales relative to how are we putting on additional messaging sooner rather than later relative to where we currently stand and what the potential impacts are for, I think it was it 48 of our, how many actual members do we know regularly use?
It's a little over 400. We've identified, on the UMR side, we've identified 400, I think it's 400 members who used an LCMC hospital in the last 12 months.
And so these negotiations do not impact the LCMC physicians associated with the health system, just the hospital facilities.
Well, but of course, if you have a pregnancy or something, arrange with the doctor that uses those.
Of course, but just to note that there is a differential there.
Yeah, and I think our employees need to know that.
Yes.
It doesn't affect your position, but it does affect the hospital, like Dr. Arden just said. If the physician only works at this hospital, that's out of pocket to you, because November 1st is closed.
Yes, and in the September Health Matters newsletter, we did put information that went out to all employees. Again, we will include that in the October. I see Regina.
But I was going to say, we want more than just Health Matters.
Yes.
We want something specific, the only message is this.
And I think
Bill shared information with me just recently this week to put together some information, so we're working on drafting the message.
It'll go out no later than next week.
Yes.
To be a separate message from Health Matters to inform our employees as well.
And targeted letters are in the mail to impacted members specifically.
Yeah.
They should be hitting their mailbox any day.
It's just, they're not going to blame UMR, they're not going to blame LCN, they're going to blame us. Because our insurance, obviously, we're the ones who provide, in part, the coverage. So we need to make sure that we're communicating what are the steps. Obviously, it's not us that are directly involved, but what are the next steps? If you have a pregnancy lined up and this doesn't go through, they're going to have to choose another doctor. They're going to end up having to pay out of pocket whatever the additional costs are.
And when providers go out of network, there is, for certain conditions in certain instances, such as pregnancy within a period of time, there is a continuity of care provision, and I think that's addressed in the letter as well.
Oh, good.
Yeah.
Okay.
Yeah.
Okay.
We don't
And we
want to
can
impact those, I'm sorry.
No, I was just going to say, we'll continue to work closely in the event we get to that point with Ms. Burris, and I know Darlene's already very, very well aware of
And
the
I think
membership.
examples would be better. For example, if you are pregnant now, and you're going to be delivering within the next 2 months, there is a provision that you will be able to use the hospital or your physician.
Yes.
But if not, you
Yes, and I know
I'm
Ms.
getting a lot of phone calls
just gonna-
about it.
Yes, and I was gonna make you all aware that you may be getting phone calls and
Yeah.
emails as I have, and as Regina stated, Ms. Gales is working with her to put out a public information.
So I'm not sure if you're aware, and you may have seen it. Of course, the first problem is someone on Facebook. So, but there are ads on Facebook. I guess targeting our area. You know,
Okay,
I saw it. I don't know, a week ago, something like that.
and Instagram, yeah.
Yeah. So I would imagine it's probably targeted. And I think it was from LCMC.
Yes, I know the CEO of LCMC put out an email a couple days ago.
Yeah, there's been
So,
targeted, because I saw it was sponsored.
Yeah, so we'll definitely get that email sent out to our employees no later than next week.
You're doing a good job, Smith. I appreciate it.
Thank you.
Thank you.
The figures you gave on the top 20 costs, is that on our computer?
It's in your.
It is, it's in
Yes.
board documents.
Yes, sir.
Yep.
I'll look for it.
It's one of the last pages. It's like the second to last page, or third to last page
Thank you.
of the total presentation.
Are there any other questions that we can
Oh, it's in-
answer for you today?
No,
Thank you all very
I think we're good. Thank you.
Thank you. If not, I just want to close, today with a bit of gratitude and thank you all, one, for choosing us to be your partner in 2024 and continuing to allow us to be your partner. We certainly appreciate your business and appreciate your partnership and appreciate you allowing us to be here today. And not only to administer your plan and provide clinical programs, but to come back and to demonstrate to you and show you how we can provide you actionable data to help you guys, USI, make good decisions to maintain great health benefits for your employees and your teachers, and also mitigate your cost as much as possible. So thank you very much.
Thank you.
Thank you.
Thank you all for your
This
time.
was so helpful.
Thank you.
Thank you.
Thank you.
With my highlighting. The teacher in me came out.
I'm not a teacher, but you see the highlighter in mine too.
Thank you all.
Thank you, Samantha. You're doing awesome.
Thank you.
We'll make up time.
Thanks, guys.
Thank y'all. Safe travels. Please grab some breakfast on your way out if you haven't grabbed any. Yes, ma'am. Thank you. Appreciate it. Thank you. Appreciate it. Thank you all. Thank you for coming. Yes, ma'am. Appreciate it.
Thank you.
Thank you, Sam.
Doing our best. We appreciate the support.
Appreciate you having us. Thanks again, appreciate it. Yeah, those top 20 are significant. Like, you're talking about the people, one that didn't have the total, the second to last page.
Yeah, oh, I know.
I mean, I know the
Yeah, no,
the prescription thing was 66, but that, diabetes is amazing. Diabetes is a major problem.
Yeah, and that's all controlled. That's all none of ours.
Yeah.
Just some,
Thank you.
off,
All right, Ms. Jessup.
just some feedback for, Oshner Digital Medicine and Diabetes.
Yes, sir.
I mean, the feedback I get from the Oshner doctors is that they don't think the digital medicine readings are reliable.
Oh, really?
The cuff, they said, was flawed.
Really?
Yeah.
Okay.
So,
That's
they,
interesting.
what I have done, I'm on a digital medicine, but I've purchased a separate monitor to compare it to, and there's
Oh, is there really?
Yeah.
Well, that's an issue, even if you're in a contract,
And
that's
what
still a
happens
problem.
is you get a false reading and you react to that because you adjust your medication or whatever.
Well, Oshner needs to fix that. You mean, I
Well,
don't think
we
we
may not
contract.
even be with them.
But I
You
have
know what I'm
a
saying? Like,
separate,
the contract's us, we gotta do that.
Well, that's what I'm saying, I didn't know where we were.
I have a primary care and I have a separate cardiologist, and both of those doctors have said, we don't trust them.
Huh.
That's interesting.
That is interesting.
That's very good to know,
That's a
thanks.
good point. Yeah, no doubt. Yes, sir. Thank you. Because, look, I'm kind of in the same boat. I could be part of that program, but I chose not to. I mean, I have my own monitoring system I use in my house, so
And they've even acknowledged it, the digital, because they have swapped out the cuff.
Then,
They've
see,
even acknowledged that it's.
but then we're still,
Yeah, okay. Just so you know, y'all, we're still live, so.
all right?
Ready or not?
Hi, good morning.
So before Mr. White gets, if you're good, Mr. President, moving on to
Yes,
the next
please,
agenda item.
go.
Retiree health insurance, as you know, last board meeting, you all approved or you all approved the district's plan relative to Medicare. At that last committee meeting, there were questions that were posed relative to retiree health insurance and the rates that would be passed on potentially to retirees and/or their dependents. There were several questions after the meeting, which we followed up with some board members for. I also included some additional information in the weekly scoop that you receive, knowing that there were some additional questions and that we did not have the appropriate time, I felt, to inform board members and make sure they were well informed before making decisions relative to potential costs to pass on to employees and costs for the district to assume. We further discussed it internally, and I didn't even have a clear understanding relative to the formula that was used on how costs are passed on to our retirees specifically in terms of Medicare and what we pay in the premiums and how the federal government is involved. While we have all, I think, gotten different parts of it at different times, I just felt it was very important for the board to have a more thorough understanding of Medicare, how those costs are tabulated, so that you can make a more informed decision. So with that said, I know I've reached out to you individually stating those things, but I just wanted to put it out officially as to why this agenda item was brought to the board so that we can have a better understanding today, so that we can make an appropriate recommendation from administration to the board at our next committee and board meeting, so that we can finalize what those rates may or may not be. So with that said, I'll turn it over to Mr. White.
Thank you, Dr. Ortling, and good morning. Ms. Beers will return in case you have some questions that she'd be able to answer in terms of specific numbers of retirees. The three things I wanted to talk about today. The first is what Dr. Ortling was referring to, is a more detailed discussion of the rates, the Medicare Advantage rates for retirees and spouses. The second topic for discussion is consideration of whether we want to formulate a policy for this particular issue and include it in our retiree health insurance policy. And the third thing is to touch upon how I'm progressing with a new overall policy for retiree health insurance. This chart, I think, tells us most all we really need to know about the Medicare Advantage plan. For the last few years, you can see what the premium that Humana has charged the district. And Humana charges the district a premium which the district pays. These are monthly rates. To the extent that any of that cost is passed on to the retiree or spouse who may be on this plan, that is withheld from their retirement check, and that money is sent to us. This premium amount is the only cost at most that the district will incur for retirees or their spouses that are on the Medicare Advantage plan. And as Dr. Ortling just referenced, that is because, and as you might imagine, those rates are very small for individuals being covered by health insurance. And the reason is, if the retirees or their spouses pay, I think it's about $160 a month for Medicare, I believe.
For Part B, it's about $185.
Okay.
Standard rate's $185 for 2025.
So retirees have to enroll in Medicare and pay that amount, and
And the spouse
Yes, in order to be on the,
185 for, an example, I'm not Medicare. 185 for me, and then it'll be 185 for my husband.
yes,
Okay.
each member has to enroll in Part A, which typically there's no premium for that, and then they have to enroll in Part B, which there is a premium that each member must pay. Yes, ma'am.
So-
That's the federal government, that's not.
Yeah,
And
that's
that's
paid
paid to Social
into
Security, and they determine those rates as
Right.
well.
So the retirees and/or spouses will pay that cost. The district will pay that premium cost. The federal government then pays all of the health care claims or all the health claims from there on out.
The federal government pays a portion.
Well, up to the extent that there may be deductibles or.
Yes.
Or,
Medicare Advantage picks up what the Part A and Part B doesn't cover.
Okay,
Yeah.
correct. So this ends up being a great deal for everybody, for the district as well as for the retirees and their spouses, because the federal government is paying so much of the cost. In the past, the rates that retirees would pay or spouses, excuse me, has been low as a way to incentivize these retirees. Could you give me a bottle of water? Give me a bottle. Thank you, sorry. Talking too much. Oh, great. To incentivize these people to move off of the base plan, which is more expensive to us and to them, and move them onto this plan, which is really financially beneficial to them and to us. For that reason, the board voted. Thank you.
That's teamwork right there.
That is,
There you
good
go.
job. You belong here.
This is the reason why the board voted to require retirees and spouses who are Medicare eligible to move to this plan. Of course, you have to be 65, you have to have paid in enough into Medicare during your career. So these premiums are very low. In looking back, the cost to the retiree has been zero. And as you can see, starting in 2023, that's when Humana gave us a credit, and they converted it into a form of reduced premiums. At that point, the cost was so low, the district did not charge the spouse for this coverage. As you can see, the premium for 2026 is higher than it's been, but it's still not as high as it was in 2021 or 22. In looking back at the formula that was used in those years, the single sheet references this. Basically, it's the Medicare Advantage premium times 2 minus the base plan employee premium times 50%. The difference is then multiplied by 50% or 25%, which is why we have two different numbers here. Using that same formula for 2026, the spouse amount would come out to zero again. It would actually, it'd be a negative number, so it would be zero once again. So for that reason, in order to keep it consistent with the formula that had been used in the past, I'm proposing that we keep it as zero for 2026.
What if the spouse is eligible for Medicare?
The spouse is required to be, it's the same rule.
Yeah, they have to be enrolled on the employee's health insurance prior to retirement in order to continue the coverage in retirement for their spouse. And a spouse has to be on the health insurance at least 2 years prior to retirement to avoid a late enrollment penalty. So as long as the spouse is on the employee's health insurance prior to retirement, they have the option to continue covering the spouse in retirement.
That's our policy or federal?
Our policy.
Our. Is this the same policy you and I have looked at?
That will be coming up
But
shortly.
this is in the same one that.
I believe it
Yeah,
is.
it's
I think,
4.6.13 retirement policy, yes.
in fact, I think we even added some language to kind of put in writing those rules in order to keep people from taking advantage of us by jumping on the
Right.
plan a
That's
minute
why-
before they
that's what I'm-
retire.
I'm going back.
No, yeah, we added that, and we also added the requirements for Medicare eligible retirees to move to the Advantage plan.
But what about retirement eligible Medicare employees? What about their spouses?
Yes, as long as a spouse is on an employee's health insurance when they're actively working, and they go to retire, so I think what you're alluding to, if their spouse is Medicare eligible, when a retiree goes to retire, let's say the retiree's not yet eligible, then the spouse can go on the Humana Medicare Advantage plan, and the retiree, if they're not Medicare eligible yet, they will remain on UMR.
Correct.
So yes, and per board policy 4.6.13, if you are Medicare eligible and eligible for Medicare, which means you've paid into Medicare, you have to go on Medicare Part A and B and then transition over to our Humana Medicare Advantage plan. They no longer have the option to stay on UMR.
Okay. And the spouse?
And the spouse as well, yes, sir. So that policy applies to the spouse as well, and I think that verbiage is in the policy, if I'm not mistaken, about
Yes, it is.
spouse.
I do remember reading
Yes.
spouse too, yes.
And dependents, which we don't really have any dependents in that situation yet.
So
I don't know if this is the right time in your presentation, or we'll address it later, but there are a few folks that did not sign up for Part B, whatever the various reason is, that they've claimed, this is 3 or 4 or 5, I don't know, whatever number is. I don't know why they can't, but everybody else can. So the whole other story, but that's, I feel like we've got to crack down on those. That's what we said. You got to do it and go. I mean, I'm sorry, I'm not trying to be a hard ass.
Yes, and we've required documentation that they've either applied and they're waiting on Social Security to approve. We do have an example for someone their Part B has lapsed for so long, and now we have this policy that they have to go on Medicare. Unfortunately, it takes Medicare a long time to calculate what their premium is, because if you don't enroll in Part B when you're first eligible, then Social Security tacks on a penalty. So for whatever reason, it takes Medicare a long time to calculate the penalty, and then I'm sure you know government shutdown and things like that.
Yeah.
It's just a delay due to staffing
I
shortages.
guess it's the fault of the person for not signing up for Part B, and
And it's
now we're easy.
ultimately, yeah.
The reason the retiree, and I say this because you're eligible at 65 for Medicare. The reason they didn't want to go on to the Medicare plan, which is our plan is phenomenal, is because they didn't want to pay the $185 a month. Because if they qualified for no premium on the other plan. And that, they were trying to avoid that, but, it was costing us, the district, an exorbitant amount of money to keep them on the other plan where they were truly eligible for the Medicaid. So it's a complicated.
No, and I know what you're saying. I guess my thing is, it's a select few, the 3 to 4, 5, that made that decision. That's a risk you took.
But we do have some employees who have retired, who is eligible for this, but they never paid into it, so they can go into it.
No, and that's not, and those are not the ones I'm referring to, but just so you know.
Those would be considered not eligible.
These are the ones that made the decision, they made the decision not to pay in a Part B, to Art's point, because they went to save the $180, $185 a month, and then now they can't get on Medicare Advantage.
So worth it.
And I just think, I don't know, I think we're potentially opening up a Pandora's box by a lot of mistake.
But I think to Ms. Beers' point, we're not allowing them.
No,
They're
not
just in the
us.
process of
Okay.
transferring
Yes.
over. So, we're not allowing them.
I'm just saying, who pays the claims, I guess, is like the question that comes in, and what plan are they on if we're paying those claims? That's really what it boils down to. What's it costing us for that? In addition, when we should be paying that?
Right.
Yes, and we are
Yeah.
cracking down on those.
So currently, we have about 190 spouses on the plan, and if the district were to cover 100% of the premiums, that would be approximately $523,000 that the district would pay. If the spouses had to pay a portion, then that cost would be less.
What's the cost,
523,000.
And how much is that a month?
That comes out to the $229.53 premium amount times 190 spouses times 12 months.
And that's the Humana Medicare Advantage?
Correct.
Okay, but if that person was eligible for just Social Security, Medicare, not Humana Medicare, but just Medicare, it would cost $185 a month.
Part B.
For their Part B, yes,
For
sir.
their Part B, if they are eligible.
Correct,
And if they are eligible, they should pay it.
correct. And they have to.
You have to pay the Part B to be eligible for that.
And they are paying it, but the district is paying the Medicare Advantage portion.
Portion of it.
Or else they would not be on one of our plans. If they want to be on one of SCPPS's plans and they're Medicare eligible, they have to pay that amount and get on this plan. They would not be allowed to be on the other plans, the base plan, high option, or HMO plans.
This is a great,
It really-
it is. I see what other people play, you know, when they retire in another company, so this is awesome.
So what we'd like to do at the October board meeting is present a plan, a proposal to the board in terms of how much the retirees and spouses pay for this. I think we had settled on zero for the retirees, which is consistent with what we've done for many years. Where we left off, I think, was deciding how much the retirees should have to pay. As I said, in accordance with the formula that was used during those top 2 years, it would still come out to be zero for the spouse as well.
I'm in agreement.
What did we, and I don't remember, I know we looked at it ad nauseam, but what did we come up with on a spouse? What did we find that 4.6.13 said about the spouses again? Or did it even cover it?
We'll
Okay.
talk about that in a
Okay, we
minute.
can deal with that.
Policy part
I'm sorry.
next, yeah. Yep.
So we'll propose that to the board, that the cost remains zero. As a follow-up, what I would like to do is have a formula similar to what was used and incorporate that into our permanent policy, which I would like to bring for a first reading in November. I had once brought it before, but there were some issues in terms of certain retirees would end up paying much more. And so in an interest to be, trying to be fair to the retirees, but also fiscally responsible for the district, I'm working through the numbers once again to try to come up with something better. So my plan would be to incorporate a formula similar to what we've used in the past for the spouses, and we can still keep the retiree amount at zero because that still ends up being a great deal financially for the retirees as well as for the district, and is a benefit to them for the service, their service to the school district. Now, moving to the permanent policy, the other thing that I handed out to you, I would ask that you glance at it, but please do not try to read it, understand it, or remember it. And if you can erase it from your memory after, I would appreciate that. But the purpose of providing you with this is I did my best to try to transcribe in writing what the formulas are for determining. The current, correct. Going through the formulas, it's the Excel spreadsheets and the references to different cells with different dollar amounts. If you skim through this, I would hope you would appreciate how complex, needlessly complex, the current formula is.
Oh, I appreciate it, glad to, so, knowing that I've read it numerous times and didn't see this, this is the best explanation I've seen yet.
Yeah, and I mean, that's really what we wanted to provide, but I guess my question, Mr. White, is this has been built over a period of time from previous CFOs, or this is not necessarily something that's given down by some authority relative to health insurance? This is something that the district has adopted internally?
Yes, sir,
But
correct.
it's always implemented in this way, obviously, since before your current role as CFO. And so your evaluation of it, you'd like to make it simpler.
Correct.
So that it can be applied across the board with a more general understanding of what's actually taking place. Because I want to be honest, this is where the challenge of this whole topic comes up, is how are we coming up with this formula on, and what is the benchmark to say, at what point do we pass some of the cost onto retirees, or not, obviously depending on the years, because the years of service matter now that we have the policy in place relative to that and the whole 2013 piece. So I do appreciate the fact that we can make this simpler so that the board understands how it's being applied.
I think at the time that the new policy was put into effect, I think there was a logic to it, but the problem is the logic translated into so many different variables that it became very difficult to carry out. So some of the objectives, and we talked about this before, is to have a policy as clear and understandable, remove the distinction between the retirees who were hired before and after June 30th, 2013. That provision was put into place simply as a cost-saving measure. Reward longevity, once again, as we've discussed before, and try to match what other districts are doing in terms of the types of things they're providing for their retirees, and still have that carve out for retirees who were hired before June 30th, 2013 and had at least 20 years of experience with us, that they would have 0 premiums. And I addressed the fact that my earlier attempt at this resulted in some retirees with particular coverages under like 2 or 3 different plans having to pay a lot more. And part of that is because the policy as it stands right now ends up with some uneven amounts that the retirees are paying. Additionally, a lot of the current policy, or my current attempt at this, had to do with trying to take how much is the district paying. The retiree will pay a certain amount, the district will pay a certain amount. How much of this amount that the district is paying should be paid by the district based on the years of service? What I would like to do now is move it, instead of having it the district share, try to cover the whole premium. So one proposal, and this is just one proposal, I want to work on this some more and try to fine tune this, but 0 to 9 years, the retiree would pay 33% of the total insurance premium. 10 to 14 years, it'd be 23%. 15 or more years, 10%. And that last provision for retirees who were hired before June 30th, 2013, and had 20 full years of experience. That is one proposal. That's the best proposal I've come up with so far. And so I would like to bring this back to the board in November. But I would hope that what you see there, it's a lot easier than trying to read this
Right.
6-page.
That's just to clarify for everybody here, that's the years, 0 to 9, 10 to 14 full years, we're talking about in St. Charles Parish Public Schools.
Correct.
Okay.
Yes, absolutely. It
Okay.
had to be for us,
Is that their full years of service with SCPPS?
as opposed to somebody who may have spent 10
I'll
years
follow
in a different district and is now working here, that previous 10 years would not apply.
And then there's other things that included, like, I'm gonna mess the terminology of it. You have to retire as whatever that requirement, like, you don't just quit. I mean, I guess.
Oh, you have to have been on our plan. You have to have had some, now I'm trying to remember what the policy says. The policy does include a provision that you have to have been working for us a certain amount of time. You can't just come in at the last second.
You have to
You can't just
retire.
You have to retire.
Like, you don't work five total years in the school system and retire, because that's not
Oh, I'm sorry, I take that back. No, what you're saying is you have to be eligible for retirement
whatever.
in
retirement-
accordance with the retirement systems,
That's right.
TRSL or LaSERS. You're not just quitting
Right, that's what I was.
working for us. You have to
Yes.
qualify for retirement, or else you do not qualify to stay on our plan.
Right,
You know,
right.
you're just considered an employee who quit.
That's what I was.
You get a letter, I'm sure.
Yes, we're notified anytime someone retires, and we schedule meetings with them. And then, of course, if someone resigns, we send out a letter when notifying them when their benefits terminate, and COBRA information.
If this comes up, should that first bullet for retirees, should it say with 1 to 9 years instead of 0?
Let me correct myself. If you are working for us and you're an employee for the district and you qualify for retirement in accordance with the rules of the retirement systems, and you retire from here, you are then automatically on our health insurance. We have to provide that policy for you, health insurance coverage, as a retiree. It would not make any sense for somebody to come work for us for such a short time if they've been working for another district, because all of the districts are transitioning, if they haven't already, to something like this, so that if they've worked 20 years in another, in another district, they'd be paying a whole lot less. They would not come and work for us just so they can retire on our plan, because their plan would be just about as good as our plan, and it would be less expensive because of the years of service they have with the previous district. My previous district just transitioned to something like this. They were paying 100%, not 100%. No matter how long somebody worked for them, they would get the same rates as active employees. And they had people moving there, getting hired there, working for 2 years and retiring, and being on their plan for the rest of their lives. In response, they did something very harsh and overcompensated. And as a result, I'm not sure if they're even in compliance with OGB requirements, requiring that you have to work for like 10 years before the district will pay any of their premiums.
Yes, that's right.
And that's what I'm
I see what you're asking.
and not zero. In other words, somebody can hire and then retire, hire today and retire tomorrow, and be eligible for.
It could be, so that's what I think he kind of alluded to, and I don't, we had looked at this. That could be an OGB thing, the state law.
I don't know.
That would.
I would
Let
like
me-
to see one there,
I
not
think it's,
zero.
yeah, I think there's something we looked at, like,
Let
I
me
don't
look
remember
into
the-
that. I think it's an excellent question.
yeah, no, it is. Because you gotta figure, you could have somebody that gets hired, works a few weeks, and something happens, some major thing in their life, and they retire, you know, to your point, I mean, I agree with you, I wonder, there was something with OGB when we looked this up.
Well, they need to straighten it out too.
I believe that's all I have. If y'all have any questions.
So just one thing on, what policy, do y'all know offhand, what's the policy number?
4.6.1.
4.6.1.
1.3.
So the last bullet there for the part of, what about just a normal employee that retires with 20 more that was hired after June 30th, 2013? What would they pay?
Currently, or under
Well,
this?
perhaps under this, I don't know if that's clear, is what I'm saying.
Oh, it would revert back to the.
Just, so they will always, even if you have 20 more, that they would always have to pay at least 10%?
Correct. And if
And
you
what
think
was
about
hired
And that's based, correct. Yeah, and that was based on the policy that we had.
Right.
And if you think of a typical insurance premium being, let's say, $800 a month, that means they would pay $80 a month. So,
Would this start with a new hire who's coming in, or would this revert to everybody?
it would revert to everybody.
So the bottom one doesn't change. Here's what it said, but you gotta look at what.
No, I know that, I'm worried about 1, 2, 3, that's the
Oh.
one I'm worried about.
If
I'm
you-
not worried about number 4, I understand it all.
Look.
I'm just, for example, my daughter was hired, so now she would have to 1, 2, 3, because she wasn't hired before June 30th, 2013, so now she would have to pay 10% of her insurance premium equivalent.
Which is, yes, which is,
After 15 years.
Yeah.
well, if you look at the policy,
It would most likely be less than would.
it's less than what it is right now.
she's currently paying on her.
Correct.
on her
These,
plan.
these rates
It's actually
are.
fixing it.
Yeah, I just wanted to know, is that what I'm understanding?
Yeah.
Yeah,
The-
that's all.
And as this particular proposal results in every retiree paying less, except for 3 who would pay, I think it's $1.42 per month more.
Thank you for doing that work.
But at this point, I still want to go back and make sure, see if there's a better proposal that would be fair to the retirees as well as fiscally fair to the district. So this is just one proposal.
But I think there's other anomalies that you're not gonna fit on one slide. And, or people that were hired before June 30th, 13,
Come back.
left, and they may have left prior to June 30th, 13 and come back after, they may have left after, come back after, I mean, and for various reasons, whether they left because of having a kid, whatever the reasons were, and can't come back,
Good question.
they
Yeah.
were technically hired before June 30th, 13, but
But I think that's a,
But that's part of, I mean, I know you're working through that, I'm saying it for the group, that we've gotta, because that's gonna be questions, you know.
I think the plan would be they get credit for their service immediately prior to retirement. If they'd been with us before and they left and come back and work for us for 2 years, they would not get credit for that previous service to us. That would be my first thought, my first proposal, because that would be a situation where they came in the last minute to try to then move up to one of these higher amounts. We want them to spend their career with us and then retire from us. If they spend a lot of time with us, go away and come back, I would think those people would have to get reset to zero.
Right, I'm talking about people that are like.
Well, I'm sorry.
No, I'm just saying, people that are sitting here sitting in our district right now that were hired before, left for a couple of years because they had a baby, at whatever point, and they've been back with us. And now they've spent 20 years, if you take out that 2-year gap, maybe they've been with us the last 10. Let's just say over a 25-year span, they've been with us 23 years, but maybe they've only, if you look at the consecutive, they've only been with us the last 12.
I think there are two ways you could look at that. To your point, how you differentiate those that have been all the way through, regardless of.
Right.
Because when you get in the mindset of trying to determine if it's a rational reason to leave or not, like you have to have something concrete. So to me, is it that you provide an exception to at least get up, like for those that have left and come back, but have, whether the difference in the time that they left is equal to the time that they're in, and then perhaps you only get up to the 10% and not the 0%, because that's different than the employee that's been here since before 2013 that has never left at all. And yet I think it's considerate of that, but then at what point, how much time do they spend? Like that's a hard decision to make, because there are so many different scenarios, and how do you apply one blanket category for every cat? And everything's valid, just like it is when employees want to go on leave for certain things. It's just hard to be fair when it comes to applying a policy across the board.
Yeah, and I'm just talking about more people were hired based on that.
And they may not have left to go work for another school district, they may have.
Moving forward, I get it.
Yeah.
One possibility is maybe give them 50% credit for the time they had worked for us before.
And Dr. Ortman, I agree with needing something more concrete, because, those are the conversations that
You're
I'm
having.
gonna have to have. So I would appreciate if something were concrete.
Yeah, I agree, and yet, then again, if they were hired before 13, left, but then spent 25, 30 years, you'd think they've shown a commitment to our school system. So that's a lot of variables. So I'm going to leave it up to Mr. Y. I'm confident Mr. Y is going to come back with a great recommendation.
The hire before June 30th, 13, I think is the caveat that is that's problematic in trying to get this, and we're look, there's no doubt you've put in the work to figure this out. It's just that one part of a sentence is problematic,
And the only reason that's there is because those people have been, by and large, enjoying 100% of their premium being paid. And it'd be a question of whether we impose a cost on those retirees at this point.
Because here's the other, and look, we can take this offline, I'm sure, but you might have had somebody that was hired, but let's say somebody that's on a retirement right now, that was hired before, maybe left, come back, and then already retired, and already getting 100% paid right now. Because think about it, we're 12 years past this now.
Yeah.
Yep. And that's a question, maybe that might be something to look up, because it's gonna be, well, this one did this.
Right.
So I would look at all, and just, I guarantee you you got somebody in that boat.
Right.
But anyway.
You probably need a little insurance advisory board when those cases come up and you make a decision how it fits into your policy.
It's difficult to have a set policy that covers every scenario.
But we want to try to have one that is as concrete as possible.
Yeah, worded broad enough that we can protect.
Minimum
us,
exceptions.
Yeah. All right.
Okay.
Thank you.
Thank you.
Mr. Wine. Thank you, Samantha.
Thank you all.
I can't wait till we get it done, because that conversation is so complicated.
It was a great conversation.
And I appreciate it's unbelievable, so it really is.
Okay, our next agenda item is board meeting. You want to take it short?
Just 2 minutes.
Short?
Just
No,
two
That's fine.
minutes.
I could also.
I doing this by myself, or are you and Dr. O participating as well? Because your names are on it too. Tis not just me. Oh, thanks. It says their names on it, and I'm gonna be back here by myself.
Hey, I think you can move, hey, I think you can move quickly and make up some time.
Oh, I got this. I got this.
Yeah, let's watch the shit that matters.
I got this.
I'll come sit with you.
Insurance since 8 a.m.
Yes, and I don't understand that.
Well, they're texting me and Josh. I'm gonna make up time. I was like, no, we're about to make up time right now. Right now. Watch me. Watch me make up this time.
Oh, I'm starving. Shelley, what's for lunch?
Liver and onions.
What is it grilling?
Lasagna, I forgot to tell you, I'm sorry. Lasagna, chicken fettuccine, fratellis, garlic knot salad, and a dessert, an Italian cream cake. I'm going to go pick it up at 11:45, set out lunch, but then I have to leave for my funeral.
Can I tell you, that is probably the hardest job, is ordering food, taking care of food.
No,
That
and,
is,
and I made sure I got chicken because Darrenisha can't eat beef and she ain't even here. But I'm hoping it's not too peppery.
I think it might be okay. I think it might be okay.
This is the first time I sat in front of her.
No, thank you. No, I miss what she's thinking. I really do miss her.
Next agenda item. Recently in the scoop, we updated the board relative to our, the board management system. As you may or may not remember, board docs will be, our contract with them, or they'll be relieving themselves from this environment. And so Diligent is kind of taking over from their perspective what board docs currently has as a service. This also provided us an opportunity, because that contract was expiring in January, for us to look at other products. So which myself, Ms. Hegel, Ms. Babineau, and Mr. Cody were able to do. So really this is a byproduct of that, and we'll kind of talk about where we see the board moving forward, and what we have chosen as our next product, which is Assembly, and some of the advantages to going in this direction. So I'll turn it over to Ms. Hegel and Ms. Babineau.
Thank you, Dr. Ortling. All right, so just to give a little bit of background, Dr. O kind of summed that up really nicely, but the company that we have now, or the platform that we have, is Board Docs. Board Docs is owned by Diligent. So what's happening with Board Docs is they're actually sunsetting the product, so Board Docs will no longer exist. So basically that kind of put us in an opportunity to explore what else is out there. So we got to kind of just put on our radar and see what are other districts using, and look into both of those products. So really there's two big contenders that we, Shelley and I, or Ms. Babineau and I, wound up coming to either stay with Diligent and move to their new platform, which is called Community, or move away from Diligent and go to a company called eBoard Solutions, and their product is called Assembly. So a little bit about each one. Diligent is a global community with many, many platforms, a global company. So they work with not just board management, they do company management, and they branch out across multiple types of platforms. Ours would be that community piece. Assembly, on the other hand, is owned by the Georgia Board of Education. It was built by the Georgia Board of Education specifically for boards of education. So there's no corporate factors. It's all based on public institutions, and especially public educational institutions. So when we looked at that and we had conversations, we were actually meeting with the Georgia Board of Education when we were discussing Assembly. And Assembly also, because it's the Georgia Board of Education, also has a partnership with LSBA. So we know LSBA, we have members of LSBA on our board. So kind of looking at that partnership as well and what benefits might be had from LSBA. So then when we sat down and we looked at both platforms, we were as neutral as possible. We came in with our board in mind, what would be the best option for us, and it was a unanimous decision between the four of us, Dr. Ortling, Mr. Cody, Ms. Babineau, and myself, to move away from Diligence Community Platform and go with eBoard Solution with their Assembly platform. We met with them, Ms. Babineau and I met with them multiple times. We brought Dr. Ortling and Mr. Cody in to see both platforms so that we can make this decision with as much intention as possible. So when we kind of looked at all of it, we met with representatives from Assembly. We also had a conversation with them about LSBA and what that would mean. What does that look like being in partnership with LSBA? So Dr. Owl, I don't know if you want to expand on that piece a little bit because you had those conversations with Dr. Pope?
You talking about, yeah, so one of the products that's associated with Assembly is this policy and procedures product. Currently, the way our team disseminates or drafts policy for the board to review is we use the company Forethought in part, okay, is a policy maker, right? So they basically take laws, like when legislation is proposed and passed, Forethought, the company, will provide what they consider to be a policy that school systems can use. We do it a little bit differently. Okay, our policies, as you know, we have a policy and the procedures is attached to that policy. Most school systems around the state do not function that way. Ours is a very efficient process because it allows us to modify procedures in a more timely fashion than our policies, whereas many policies across the state are more detailed in nature, right? Even the recommendation that we get through Forethought. So it takes longer to implement those policies because you have to go for a first and second reading. But as you know with us, our procedures are defined to be more specific and our policies are broader, but they're attached. So because of the way we have our policy and procedures, the way we currently draft policy is we follow law, our staff members are each specified to review pertinent potential laws that fall kind of under their purview, right? We track laws as it goes through the process. Once it becomes law, we as our staff initiates either first development or refinement of our policy. Okay, if we feel confident that those refinements, based on our knowledge, and sometimes we'll seek legal advice on those things, then we can bring them directly to the board and say, look, we need to change this policy, this law changed this. However, there are also times when Forethought will provide their synopsis of their interpretation of the law and how that should be applied via policy. We take Forethought's, and Ms. Smith kind of oversees all policy and procedures, but different departments look at specifics. But we take Forethought's summaries, and then we sometimes take language out of Forethought's recommendations and apply it to our policy, and certain parts of it to apply to our procedure, to fit it the way we need it for St. Charles Parish Public Schools. So when we looked at Assembly, right, their platform, their digital platform, some of the unique parts or functions of the platform, we've never had the opportunity to have. Like Assembly's platform allows you to search, let's say AI policy. Everybody that has Assembly, you can get 50 different policies of AI simply by typing in a search word, by going with Assembly. Like, that's just one functionality. It also had the function to directly tie in our long-range strategic action plan and goals, almost as a check mark, like as a progress monitoring piece, directly tied into the same platform, that we all use, instead of us tracking those things in a Google Doc and then putting it into a presentation format, telling you where we're at, like we can literally progress monitor. And those are just two small functions that really make Assembly far and above what we currently have in board docs. And that's not even the board management, like the board meeting side of it. But the other function, because LSBA is directly connected to Assembly, they now, LSBA, as you've seen through their updates, and I'm sure Ms. Weber can interject after I'm done, but they now have a policy function. So they are basically doing the same function that Forethought has done, okay? So, however, because they're now part of the platform, right, their kind of recommendation was to push down their policy versions down to all systems that use Assembly. Well, our policies are not formatted that way. So that was a holdup initially with us. I reached out to several school systems and school system superintendents relative to that. And then I reached out to Dr. Pope. Because our policy and procedures, and really Dr. Pope said the same, ours are really the way all school systems should operate relative to prioritizing the policy and then procedure. But they had to figure out a way that we could still keep our format, but still potentially use LSBA's services relative to what their recommendations are for policy. So, long story short, they work with Assembly and have agreed to modify it specifically for St. Charles Parish Public Schools so that we can still house our board policy and procedures similar to the way we currently have them, still utilize their policy services basically the same way we're using Forethought, basically using it as a checks and balances against what we already do. We already have, to me, a process in place. While it is more work on our leaders, our team, to me it's the appropriate work because we're the ones most closely aligned to the work in the system. We know how our policy procedures operate. We still use it as a checks and balances, but now we will be able to capitalize on the functionality of Assembly while also having a platform to use our policy procedures, but it does come at an additional cost. So for that modification, there is a slight increase in cost. Assembly in general is more costly, but I'm telling you the product is pretty significantly more than what we currently have in board docs. So that's the whole LSBA kind of involvement because they are directly attached and they have a MOU with Assembly. In order for us to use Assembly, we have to use their policy services, except now it has been modified in a way that we can utilize it still with the way we set up our policy procedures.
Do we have that in writing? Like permanently, we're not doing like a one-year thing that LSB cannot go and change this? Like,
That's correct.
As long as we're contracted with you, this is the way we're doing it.
That's correct.
If not, we're out.
Yes, sir.
Yep.
How much are we paying board docs, how much are we paying?
That's on the slide.
That's on the
coming.
slide.
I'll get there, I promise.
It's coming up, Ms. Ellis.
So right now, and this kind of goes with that cost feature, is that with Assembly, they have 6 different, basically modules within the program. We're only going with 3. There are a few other ones that can be added later, so I linked their product brochure so you can see the other ones, but what we are going with are the board meeting management, so that's what happens right now when Ms. Babineau's over there doing her thing and you guys, and then we go to board meetings and everyone votes. That's that meeting management part. The second part is where we store our policies. So within there, there's a better workflow too, which doesn't really affect you as much, but there are some interesting features where if you go in before a board meeting, there's sticky note features where you can take notes on things that you might want to say during a board meeting or during a committee meeting, and then that's only saved for you. So nobody else can see it because you're logged in as yourself. So that's an interesting feature. And then the planning piece, which Dr. O explained about keeping track of the LRSAP as we progress through the year. And then for within that timeline, Shelley and I right now are working on documentation, contract, getting everything squared away so we can start moving the back end. We have to export all of our stuff from Diligent and move it into Assembly. So we're working on that piece. We also are going to meet with our trainer so that we can establish a training timeline for executive staff, for ourselves, for you as well, because it's just a little bit different and we want you to be comfortable when we start that launch, which our first meeting that we will launch live with Assembly will be February because our diligent contract runs through the end of January. So we'll start our February in the new boardroom with Assembly. So we'll have you comfortable and ready before that point, but just to give you some idea of what the timeline and how that's going to work. So here's that cost, Mr. Ellis, as far as what we will be paying into the meetings portion, the plannings portion, and then that LSBA portion. So it runs us about 32. Right now for board docs itself is $6,000 per year, but the community shift, so Diligent is raising that price, it's going to move to $16,600. So the moving from board docs to community will be a $10,000 increase. So this is more expensive, but it also has way more functionality than us moving to community. We'll be able to keep track of our policies better, our workflows better. Just that LRSAP part alone it's really nice. It's a really nice platform. Mr. Cody was really impressed, which I feel like that's hard to do because he knows platforms so well. So it was very clear that it's going to be worth it.
And also, Ms. Smith, how much is the
Right
four?
at $6,000 what we pay for it.
So,
So they-
now the 6,000, correct, so
16 plus 6.
plus the 6 for forethought, because if we go with, obviously, when we move with Assembly, we would no longer need forethought. So
Yeah.
really, you're looking at 22,000 compared to $32,000, what we would be paying, and as Ms. Hegel said,
Yeah.
a lot more. And the other thing that was real
With that
important to us, and I
LRSAP.
think to Ms. Babineau, is the responsiveness
Yes.
of when you have issues, right? Because with board docs, that's been,
Diligent is global. They're everywhere now. When it was just board docs and their cute little company, you could get somebody on the phone, it was local. Now Diligent's worldwide. And so you might get somebody in Sweden in their pajamas talking to you. Assembly is local here in the United States, and that's all they do, is board and district management. So I just think it's,
and if there's any indication, we had one presentation from Diligent and one presentation from Assembly. Assembly's was scheduled for 1 hour. After an hour and a half, we had to leave the meeting. Assembly's was scheduled for an hour, and they were 30 minutes. So that tells you the detail and functionality of some of the functions within Assembly that we're excited about. We really are excited about, to see the cross-connectedness between long-range strategic action plan, between policy and procedures, and just a modern platform to use that I think that you all will be pleased with, and we're certainly anxious to Ms. Babineau's.
I hope it's easy to learn.
Anxious is the right word. Anxious is the right word.
Yeah,
I hope it's easy to learn, and I hope it's easy to teach.
I mean, you're the one that's doing the work, you know, so I feel like you're comfortable with this. I saw the presentation, I know all about it as well. It is a great, but I will not be voting on it, you know, because of my connection. But it is, I do like, I have to agree with Dr. Bartlett, the policy piece is very
And
impressive.
each piece talks to the other one, so
Yeah.
it's integrated. It's,
And all linked.
Yes.
Well, in my view, this is just a matter of time, because I attended the Diligent conference a few years ago, and you could see their focus decline, and their
Yep.
focus on board docs
absolutely.
really decline, and it was just, board docs was kind of along for the ride, but that really wasn't their focus.
Somebody said board docs was like having a flip phone. I mean, it's from 2007 or 8, whatever. It just
That's not
needed
their
to be
moneymaker,
updated.
so they're not
Right.
putting as much focus and energy.
ESG, I mean, those,
Right.
like you said, being a global company, they're focused on
You
other
came to
things.
the last
Yeah.
conference. It was not about board management at all, so.
All right, that's all we have for
Okay.
that part.
Do we, how much does it cost us to be a member of LSBA?
I want to say it's,
It is based on enrollment, so I want to say it's like $15,000,
15,000,
$16,000 right now, currently.
15,000.
Between 15 and
And this
17.
module costs more than being a member. Isn't
Well,
I have a conflict.
because she's on the board of directors.
I'm a board member of LSBA, so
And
I
Cindy's one of
can't,
their-
yeah, I can't
one of their
vote on
small-
that, but there are other parishes, their board members have voted on this, so if there was a conflict, I don't think something that would be presented to you to even purchase, if it was even an idea to have a conflict, because I don't see that, because other parishes have, St. James has it, am I correct?
Correct,
And there wasn't a
St.
conflict of
James, St.
interest there
Bernard.
for the board members, am I right?
correct.
And there is one person that serves on the board of directors. No, I'm sorry, I'm thinking of St. James.
There was hesitation, you know, I would say that was probably the largest part of our discussion as a committee relative to that, Mr. Ellis, and it took, and we would not have even, we would have rather stayed with Diligent, but the functionality, Diligent is a very basic platform.
I
Yeah.
understand that.
Again,
I
cost
understand,
cost
you
benefit.
know, that
By law.
something is tailor-made for us. But it seems to me like we might need to pass this by the Board of Ethics to see if
Well, we
there's
can
not
get
a
legal
conflict.
advice.
Or maybe Pat Almody.
Yeah, I'll follow up on that, Ms. Ellis.
I would maybe get an attorney to write the letter to the ethics board. Because it seems like something shouldn't be, you know,
The
pay to
product
be
is
a
owned by
member
Georgia
of
School Board.
LSBA.
Mm-hmm.
And LSBA is now in business.
I'll follow up with that, Ms. Ellis.
Yeah, and
I
you
will.
might want to ask other parishes, because they're doing the same thing, so
Well,
there's a lot of people that can be in ethic violations, and so I'm thinking we might want to, reach out and see.
Our contract with Diligent is an annual contract.
Yes.
And we fulfill that by the
Jan-
end of January.
Yep, January 31st.
We'll follow up with legal
Yeah.
counsel, Ms. Ellis.
Assembly is a Georgia School Board product. It's owned by Georgia School Board, so.
It doesn't,
Yeah,
But, you know, it seems like if Georgia school boards developed this thing to begin with, it seems like our IT department might be able to develop exactly what we need.
Yeah, that would.
Nothing
not
like.
before that,
Nothing-
not before that reorganization.
That would cost you way more.
Not-
than
I was gonna say,
Okay,
wait,
moving
let's
on
talk
to the
about that in the
next- to the next-
spring.
Nothing like Assembly can provide. I mean, I love
Speaking
Kelsey,
of.
but
Speaking
I
of.
don't know what the deal is.
It's-
If somebody created this,
Yes, sir.
somebody else can create
Don't
it.
want to go there.
It looks like a very good product, but I know we want to move on to ITS updates,
Go ahead.
Ms. Eagle.
Yeah, absolutely. All right, let's do it.
I'm good.
thank you guys.
All right, so I have a very brief ITS update. I just wanted to inform the board. Basically, we were all, Dr. Ortling had sent in the scoop a few updates about the AI task force, and AI has been such a hot topic. The board has asked me many questions about it. So we had our first meeting this week. So I just wanted to give you a little bit of an update on how that went. So our AI task force, Matt Chauvin and I are the co-leads on it. So what we did was we broke it into kind of two pieces. The task force itself, which has representatives from all departments and schools, and the teacher pilot, which is focused solely on the actual platforms and teaching those platforms. So the task force's job is going to be to bring, in the spring, I will bring forth a policy for AI for St. Charles Parish Public Schools based on the guidance from the people within the task force. And the pilot is for the teachers to actually go through and use those platforms to give us that feedback. So just a little bit about our first meeting. We held it on Monday. We had 72 participants, so we have about 35 in each group, which is a really good solid number of representation. Dr. O spoke to the participants in the beginning of the task force about basically what his vision is and what our vision is for St. Charles Parish Public Schools as far as this task force. Then Matt and I went through and we focused on the implementation plan and basically what our end result is, which is to bring that that St. Charles Parish Public Schools guidance back to you with a potential recommendation for purchasing an AI platform for the future. And we also went through that LDOE AI guidance. There's a multi-page paper that has come out from the LDOE. So we had groups go through and really look at what is the LDOE guiding us and how are we going to continue and adopt some of their things, and then how are we going to own some of it ourselves in St. Charles Parish. So within our just plan in general, and Dr. O has sent this in the scoop, I also linked it at the bottom, which is our implementation plan. So a little bit about that. It just goes through the purpose and the vision of why we're bringing all 72 of these participants together, what's our end result. We're looking to do a few things, which is innovate, which is make all of our stakeholders aware of the newest trends in AI, including for teachers specifically, the ability to teach students about AI. Students know AI, they probably use it more than our teachers do, but we want our teachers to be comfortable and confident in teaching students about how to properly use AI and the ethics behind that. So that last bullet there talks about being safe, being ethical, and being equitable, making sure that all our students have that access and those abilities based on computer science standards from the LDOE, based on the digital literacy standards, and based on the AI guidance that was delivered by the LDOE. Our guiding principles, we have a few in there. You see our keywords bolded. We want equity, we want access, we want ethical and responsible use of AI. We want our students to know how to use it, but use it properly. A lot of the concerns from the teachers was plagiarism and cheating, and we know that has been a common topic. So teaching teachers, one, how to identify that in student work, and two, teaching students how to best utilize it without actually cheating and plagiarizing. So we want to make sure that our students and our teachers all understand what we view and believe as St. Charles Parish Public Schools. Looking at it as a tool, not a replacement, so we shouldn't be using AI to replace things that we're using. It's a tool to enhance, just like the calculator, right? So we want to think about it that way, and we just want to look at making sure it aligns to our district goals and the state goals as far as AI is concerned and as far as standards are concerned for students learning. Some key features are goals and objectives. It's kind of four-pronged instructional because we have all of those teachers in that AI task force pilot. So what will happen is they will learn a product and platform. They will have 6 weeks to implement. And then a new vendor will come in, train the teachers how to use it. They have 6 weeks to then implement that one. So we chose the biggest vendors in AI right now for teachers and students alike. So we have that plan set in place. If the teachers by the end say we don't like any of these platforms, then we start fresh next year with new ones, making sure that whatever we go out to purchase and use and have become part of our AI identity as St. Charles Parish Public Schools is universal enough for instructional needs, but also you'll see that second bullet, which is operational. We didn't want to leave out the departments. We want to make sure that all of our departments, we have representatives from HR and payroll and the copy center. We have everyone represented to make sure that we are using AI effectively operationally as well. Professional learning, we want to make sure everybody's prepared, everyone's knowledgeable, and then that policy piece is really important. Calcasieu came out with a really great guidance based on the LDOE AI guidance. We want to make sure St. Charles Parish has that too. If we're going to continue to lead the way in technology and innovation, we need to have a stance, and that is what this document will be by the time we're done with this task force. Just a few little timelines for you so you can kind of see our broad scope. We will meet 4 times this year. As I said, the first meeting was this past week. So each time we have 2 hours with the task force, which is going to be focused solely on that policy, and that second 2 hours is training and debriefing for the teacher pilot piece. So we can, hopefully they're going to bring us videos and samples of the things that they've done with each one of these platforms. And that's really it. I didn't make it too long. I just wanted to kind of give you the brief scoop of kind of how AI Task Force is working. Do we have any questions on my task force? It's pretty comprehensive, I know. It's a
Ms.
lot.
Ellis?
He needs to talk to ChatGPT first, and then he'll get back to me. All right, if there's no questions.
Thank you, Ms. Eagle.
Hey, when you got on the board 18 plus years ago, did you ever think you'd be dealing with artificial intelligence?
Well, you know, a long time ago, when calculators can't want to see, they were banned from classrooms. So
Yeah.
They say they were protested by teachers and everything,
same
so
thing
it's
all
been.
over again.
I do believe we do have some artificial intelligence sometimes around us.
So,
We have some people that might have some artificial intelligence going on.
so Ms. Babineau's checking on lunch, so as we move forward, we move on to the next, Mr. President, next agenda item,
That's what I call them
which is our LPAC update. We have Mr. Moore and Mr. Martin. You can go
I
ahead.
realize I'm the last thing standing between you and your lunch, which is never a good place to be as a teacher, I remember. So I'll try to be quick and really concise. I know I had about 15 minutes in the schedule, but please feel free to ask questions as we go. I like to stand up too. I'll try to be energized for y'all this morning. I even sit down a lot. So it's wild that I was here about a year ago on October 25th last year, sitting down, cutting time between running from my classroom and back to my classroom to give you an update on a job that I had very little knowledge of as I was walking into it. I'm very proud and pleased to say that this has been the most amazing career shift of my life. I'm really blessed every day. I feel so grateful to have this job, to serve alongside of you. I think we've seen some tremendous growth at the LaFawn Center in the 12 months that I've been in the role. I presented a lot of big ideas to you last year about culture shifts and mission orientation, and I'm really proud to say that I think we've achieved all of those goals, specifically around shifting the internal culture to be more communicative and welcoming, around supporting our school programs first as our first priority, and doing building up our local and regional outreach to build partnerships and boost awareness of the LaFawn Center. These are things that I presented to you last year, and I think you'll see that we're really on track to do that. So thank you for the opportunity, as always, and for your collaboration. This is just a quick overview of what I'll talk about. I'm going to go through some highlights from this fall and some new program initiatives that we've got cooking up and underway this season. I'm going to go through the needs assessment that I've been conducting since earlier this year, as well as some operational updates that I just want to make you aware of. Give you a quick season update and then a brief touch on where we're at with our messaging strategy. So again, I'm going to move quickly, but feel free to interrupt as we go. So just to recap, we had an amazing kickoff event with our beginning of the year with Mr. Gregson, Dr. Ortling, and all of our guests. We have expanded all of our reach. We have a lot of part-time staff now. We've filled out those roles. There's some great shots. I love this one of Mr. Ellis. Who is that handsome man?
That wasn't you who took that, huh?
It was a tremendously successful event and a successful day. One of the highlights for us, as you remember, we passed out over 2,000 souvenir cups to our employees, which all included a 15% employee discount code, driving home our theme of You Belong Here. I got all kinds of texts and photos of people just being so grateful. They had never received anything like this before. It was a great gesture. We've had 120 employees take us up on that offer since that event, so that's really great that people are taking advantage of that discount. In addition to that, we've added all of those 2,000 employees to our mailing list for the Behind the Curtain newsletter, which is our new newsletter. It goes out once a month. You should all be getting it. If you're not and you would like to receive it, let me know. We also have now a free membership level to our Friends of LaFawn program. That means that you can just, it's like a loyalty program. You can just sign up and get the newsletter and learn all about the things that are happening each month. It's a great read. It has over a 50% open rate, which is very unusual for a newsletter. It's extremely high, so we're really proud of that. People really want to engage with us and know what's going on. Even people who
That's
don't
higher
have
than our
tickets.
insights. My insights is only
Yeah,
37%.
Sorry, Dr.
Not only 37%
Sorry to
open
break it
rate,
to you.
man.
That's pretty good. 37%.
Regina, let's get on that.
What's your open rate?
That's like 37%, isn't it? It's like 30 something. Yeah.
So that's a,
We're gonna have to attach it to that.
Man.
We'll link it in the
Yeah.
LaFawn newsletter.
Exactly. Go ahead, Dan.
We'll plug you, Dr. O.
Please.
both those numbers are when you look at the norms across email marketing.
Yeah.
Those are through the
They're
roof.
through the roof.
Both of them, even the 37.
People are curious. It's what it's telling us, right? Is people are really curious to know what's happening at the LaFawn, and we're now in a position where we're really able to tell them. And so we're cultivating that audience. So what's new? Some recap over what student programs have looked like this fall, and this is specifically with regard to this push that we're making to involve our students more publicly in our season shows. First thing that happened in August 15th, we had 25 elementary talented theater students and 15 home study families participate in a professionally led playwriting workshop by Goat in the Road Productions, their professional theater company. This was a really fun event where they perform plays written by students with a cast of adult professional actors. And this company goes into schools across St. Bernard and Orleans Parish currently and writes plays in general education, English classrooms, ELA classrooms with 5th and 6th grade students. They hold a competition at the end of the year where the students submit their plays, and then if they win, they see them performed by professionals. They see the student on a throne on stage and watch the grown-ups perform. It's a great time. So they just gave us a taste of that by performing 4 of these student plays for us. They led a wonderful playwriting workshop afterwards. We had a nice little banquet right before we lost power that day. So those were really successful events, and we're excited to continue collaborating with them. In addition to that, shortly a couple weeks after, on September 12th, we had 50 middle school choir students rehearse and perform with the public with the Sharp Family Singers for their show the following day on September 13th. We had 900 6th grade students in the audience for this art experience. I believe Dr. Ortland was there. Y'all, it was like the Beatles were in the house. These folks have over 10 million followers on social media. Most of us in this room do not know who they are. I guarantee you every single middle school student knows who these people are. It was a phenomenal event for our students. Everyone was jealous of the 6th grade that they got to see this. We even had our first proposal during an art experience happen. But yes, that is a student proposing to one of the performers on stage. It was absolutely precious. The videos that they shared of, they filmed themselves. They're influencers, so they filmed themselves while they were performing. It got over 250,000 views on Instagram alone, and that's to say nothing of their other platforms. And they tagged us, they showed us off. Our social media following as a result of this one show grew 30%. So our goal was to grow ourselves from 600 followers on Instagram to 1,000. We're already at 920. So that was like a big win for us with this show, in addition to, of course, the experience the kids got to have. That's awesome. So Dr. O, I know you want some.
I have over 1,000 followers. And just so I can clarify, because Regina did just send me the numbers. October Insights, open rate was 77%. But the click rate, which is how much they click on it, my message is probably like 20%, but it's 30%. So
That's actually, both are very strong.
Yeah.
All right, we'll be in friendly competition.
Bring it on!
Let's go!
And finally, we had 45 high school talented theater students participate in a professional improv comedy workshop with St. Rose native and New Orleans comedy legend Chris True. I learned in talking to Mr. True that he was grew up in St. Rose. He went to SCB. He's written books on improv comedy. He runs really successful comedy festivals. He MCs music festivals and things all over the country. And he is so excited to continue working with us. This was a very easy lift for us operationally, had a huge impact with the students. I got texts from both Hahnville and Destrehan High School theater teachers saying things like, this is what we've always envisioned this center being used for. This was just like tremendously positive feedback. And the photos speak for themselves. They just had such a good time. And they learned a lot, right? You learn a lot from improv comedy, a lot of confidence building and strategic thinking, not just how to perform on stage. So, those are just some of the programs that we've done. Remember, in February, we'll have CeCe Tennille performing on February 28th with 100 high school choir students to open the second act of her show with her arrangement of Bridge Over Troubled Water. That is going to be a phenomenal event. I encourage you all to come. And then we'll close our season on the Evening of Arts Fest with Mandy Gonzalez, who's a Hamilton cast member, close friend of Lin-Manuel Miranda, who wrote Hamilton. She'll be performing with the LPO and a choir of middle school students singing an arrangement that's yet to be determined. But both of these events coming up are really going to spotlight our students in a big way. We're really proud of it. We're really excited. So more to come. Other things that are new programming-wise, we started our community series. We had our first ever Super Stand-Up Saturday in the Black Box, and we sold it out.
Yeah.
It was a great time. We rented tables. We had the bar there. And we really learned that people in St. Charles Parish, especially younger parents who are looking for something to do, want a club-like environment that feels accessible to them, that feels, they've got free parking, they've got easy to line up childcare for a couple of hours. So we're going to keep doing things like that because we actually turned a profit on this event. It wasn't a huge profit, but we broke even, and that was a sign to us that we're meeting a need for the community. And when it comes to filling 1,300 seats, that's a tough job, but when it's just 100 seats or so, that's nothing for us, right? And so if we can really meet people where they are, do things like singer-songwriter nights, stand-up comedy, jazz nights, all those kinds of things, they're a really good time. We also had, I want to say about 20% of our audience was brand new to the theater. They'd never been there before. So it's a great way to introduce new folks to the center. We'll hold a film screening with the St. Charles Parish Library on November 3rd in collaboration with the National Holocaust Museum in DC. So if you're interested, they're manning registration, but that'll be another kind of interesting pilot to see what comes of that. And our Nutcracker tickets are now on sale. We're doing great. They always do great things for us sales-wise, and we're excited to collaborate with them again. If you're curious, they've changed their company name from River Region Ballet to Ballet Images. So just in case you're searching the web for River Region Ballet. Any questions about our community series before I continue? So I'm going to move into our needs assessment. This is something that I've been really focused on since March. It's been a huge part of this culture push. We've conducted focus groups with 19 administrators. We've had, and one-on-one interviews. We've had focus groups with our arts leadership team, which is about 25 arts teachers, feedback session with the Superintendent's Advisory Committee, surveys and focus groups with our AM/PM employees. We have a roster of about 40. We've surveyed all of the district arts teachers and program leaders. It's about 70 teachers. We held a retreat for our staff. That's full-time and part-time, which is about 12 employees. And then feedback and brainstorming sessions with the folks who participated in our inaugural District Arts Calendar Committee, which we've now narrowed down to a more serious ongoing committee. But those are just, and that isn't even all of it. So this is all just to demonstrate that we've been talking to everybody, right? We're really valuing that feedback. And I want to share with you some key takeaways of what we've learned from these surveys and conversations. Number one is that every single stakeholder we talked to reported feelings of pride and gratitude for the educational opportunities that we afford at the LaFon, right? So we're doing that really, really well. Nobody is mad that we're doing what we do for students. Two, various stakeholders reported differing perceptions of our programming priorities. This is very much in line with what I told you a year ago when I said it seems like we've got some mixed messaging around who we prioritize and how. What that means is, as an example, those who run dance recital studios in the area, they think we have different priorities than the artists or audiences that we have for our main stage season. And those, of course, are sometimes in contrast with our teachers who think we have different priorities. So that's our job to message this more effectively. And that's some of the work that we're really focused on doing is how do we make these priorities clear and digestible to everybody who walks through our doors. Number three, teachers and administrators reported inconsistent communication around our decision-making process. This is especially true with regard to scheduling. As I'm sure you all know from having worked as administrators in schools, scheduling is one of the most difficult hurdles in the district calendar process. As Regina knows, is extremely difficult. For us, it's really hard too when we don't have our priorities straight and we're not communicating them clearly. So this was no surprise to me. And finally, teachers reported, this is arts teachers specifically, did report logistical hurdles that sometimes come along with hosting events at the LaFon Center. Of course, we have safe schools protocols in place for doors. We have a lot of doors in our building, as you're aware. So we are taking some steps now to respond to this feedback immediately. There's some short-term stuff and some long-term. In the short term, this is huge, based on the feedback that we got from administrators and teachers especially, is providing bag check services for all school and district level arts events through our third-party service, which is NOLA protection. Right? Thanks to Mr. White, we were able to budget for that, to take the lift off of the teachers and administrators who would normally have to miss their students perform while they stand out in the lobby and do bag check, so that we can take that logistical burden off of teachers. It got an enormous round of applause when we announced this to the teachers, which tells us we're doing a good job of that. Teachers will still be providing their school resource officers for those events. That hasn't been as much of a pain point that bag check really has. We have now been staffing ushers via AM/PM for our school and district arts level events that require ushers, which again relieves teachers of having to, in addition to coordinating their event and the 100 students they have singing on stage, they've also been having to coordinate parent volunteers to serve in the lobby. We're taking that burden off them now. And then finally, this is another big one, win for teachers, is historically, maybe y'all are aware of this, maybe you're not, we've insisted that teachers come in during the school day or after school to hold in-person production meetings to plan their event 4 to 8 weeks prior to their event. We've now shifted this to be virtual as an option for teachers who are returning, meaning they've already done an event before with us, and anybody who's not a theater production. I don't need to get too in the weeds of that, because I'm short on time. So, all to say, in addition to these things, the Arts Calendar Committee has been rocking and rolling. We're really thrilled to have representatives from all over the district now weighing in on how we schedule our events, and then optimizing our day of event staffing and logistics. I could get into more detail. I'm happy to answer more questions about that. These are just some of the steps we've been taking. Real quick, I'm going to give you a brief season update. We are 3 shows in. It's been a wonderful start, and we're learning a lot. So, just to kind of go through some attendance details, you can see we have not broken yet through that sort of 25 to 40% range that we typically see in our season shows. We did sell out Super Stand-Up Saturday, and Menopause the Musical 2 is projected to sell out all 1,300 seats right now, which is phenomenal. So that tells us something about our audience and what people kind of want to come see. We will certainly stand to profit from Menopause in terms of the hard costs against the cost of bringing people in, as well as the Nutcracker. We will usually turn a profit with the Nutcracker too. Other shows that are still open, we'll see how it goes, but right now we're pretty much on track with where we were last year. Again, hoping to do better attendance-wise so that we can really push through that barrier we've been hitting. Any questions on that? All right, I want to talk quickly about revenue, and just to kind of give you some context on where this is, right? This is the only things that these figures include are revenue from ticket sales, as well as corporate sponsorships. We have a sponsorship from Shell, from the hospital, as well as now Hancock Whitney Bank. We gained a new sponsor last year. We're working on some new sponsors as well. You may see a trend here, right? In 22, 23, we came back from the pandemic. We were at 194. The next year, that revenue grew. It shrunk a little last year, and our goal for this year is even lower. And you may be asking, well, why are we seeing this downward trend? And the answer is because between 2023 and 2024, we added 7 shows to our season, right? So when you added more shows, we spent much more money on shows, and then we made some more money. But last year, on 24-25, we did the same number of shows that we did in 23-24. Again, we spent a lot more money on bringing those shows in. And this year, we're only doing 10 main stage season shows. So we're cutting our expenses significantly this year. I'm happy to elaborate on that if you're curious. I do have those figures ready for you. But suffice it to say, this is actually a pretty ambitious revenue goal for us this year, and it may change. But we feel pretty confident that between the interest that we have brewing in corporate sponsorships and how we've been doing with ticket sales so far, that we should be on track to come very close to this goal. Any questions on our revenue at this point? Happy to answer. Yeah. You looked like you had something, Mr. Bell. You good?
You ever heard of a fellow named Kyle Russell?
Have you?
No, he just sent me a link then.
He attended Montville High.
Okay.
And he auditioned for Nova. And he graduated from Nova, but he's from Boutique. I think it'd be nice if we try to get him to have a performance at the theater.
We'd be happy to facilitate that, yeah. We can certainly get in touch.
Thank you.
Noted, thank you.
So you said cutting costs, where does that come into the, that's a gross revenue, right? That's not the.
Correct.
Okay.
Yeah, this is just ticket sales and sponsorship. So I'm not showing our expenses against revenue here, right? So to be clear, we're not showing expenses here. I'm happy to get into expenses if you have questions about it.
No.
But this is what we're bringing in just in our public season as well. This does not count ticket sales from school programs, which all goes directly back into the schools, as well as concessions. All of our revenue from concessions for school programs goes directly back into the schools. This does not include our revenue from the bar, from individual contributions, or from concession sales. Okay?
And perhaps in the future, I know you provide quarterly reports, is maybe kind of have that breakdown as well, because that would be a good point.
Certainly. I'm happy to speak more in depth on that as well if you want to see the costs.
Just in the future.
Sure. All right, this is some exciting news, pun intended. So we've recently partnered with a PR firm. It's the Earhart Group based in New Orleans. This is the short list, y'all, of the publicity that we have had in the past month since we have engaged them. We started working with them in late August. We've already, I think I've appeared on TV like 6 times since that month we engaged them because of their really strong relationships with local media. So I've had 2 appearances on WWL now, one on Fox 8, one on WGNO, and one on WDSU. We've had, I was on the radio on WBOK. I've got another radio spot lined up at the end of this month on WWL radio. It has just been like wildfire with the media since they have gotten on board. So that means that we have expanded our media reach exponentially since before we had them on board. Again, we're not seeing this result yet in a conversion to ticket sales across the board. We'll know more at the end of our season when we have more data. But suffice it to say, the word is really getting out and a lot more visibility is coming our way. And just to kind of catch you up to speed on where we're at with some of these other marketing initiatives, the other company we're currently working with is Deep Fried Media. They will be in the building on October 29th and 30th shooting a 5-minute marketing brand video for us where we'll be featuring students, teachers, artists of all walks of life. We're very excited to share that with you and should have that to share by the end of this semester. They've also been working with us on some key messaging updates, website upgrades, and social media strategy, which again, we're compiling those things, but the deliverables they've shared so far are phenomenal. And I think the thing to share at this point is they're really pushing us to lean in to our leadership as an arts education center first. And that's what I really want to be clear to you about is we are truly leaders in this field nationally right now, and that is what we are going to be really promoting and communicating very loudly to the rest of the world. So again, I love your collaboration in that, but I just want to kind of give you a heads up. Any questions about this? Great. And the second slide is just to say the Earhart Group has been helping us, whereas Deep Fried's helping us tell our story, the Earhart Group is helping us get that story out into the world. So if you see me on TV talking about us, usually I'm going to be focusing on things like the art experiences, the student shows, and the work that we do with teachers in the community. Okay, I think that's it. I tried to go really quick. I try to keep it in my time. I know y'all are hungry, but any questions I can answer for you at this point?
I'll just, this past week, first of all, the legislative wrap-up session that we hosted, or that, Ned and his team hosted at the center, very positive reviews and feedback from those that had attended. In fact, the next day, Representative Billings reached out to me from one of her constituents or representatives or one of the governor's faculty members or staff that's in charge of organizing the celebration of Louisiana's 250th celebration. So they are going around different regions of the state to celebrate the 250. So she reached out to see if they could coordinate possibility of using the LaFon Center as one of the places to host a celebration of the 250. So one of the reasons we agreed to host that event, right? We didn't really host it. We provided the venue for it, was specifically to expose more people to it. So I think you all do a great job, Mr. Moore, of doing that and highlighting. And although it was a challenge, I'm sure, to coordinate in a short period of time, it was well received. So I just wanted to mention that. And I think the job you're doing relative to, the exposure, the work with the Earhart Group. I know Mr. Martin with the endowment board and all the work that he also coordinates with the schools. We're really providing a solid highlight, towards the center and what it provides for our community and what it could provide our regional people as well, community as well.
Thank you.
Yeah, and I think the one thing I would like just to add, we are arts education, and not to forget about those disciplines that are at the LaFon, to include them as much as you can in other productions, like technical theater, piano, dance, all of those things, because from where I'm seeing it and I have gone, it's your talented theater people that are coming from the schools. It's choir, it's music, but we have so many other disciplines that we need to get them involved, because that is the next stage of their lives, because they're in high school. So that could be a career that they may be thinking, and we don't want them to go to NOCA. We want them to stay here and learn the craft that they want to learn. So that, and that I see exposure, although we're doing a great job of marketing of Alonzo.
I think you're gonna really like our website update, the video we make, and the way our messaging is gonna turn, because that's a huge component of what Deep Fried is proposing, and that you're going to start seeing much more visibly from our public presence, is everything that happens in those satellite center classrooms, in addition to the performing arts work. So thank you for that. We're excited to
I mean,
share.
I'm telling y'all are out there, 'cause I see it at every event, you're there, you're handing out, I think that's very critical.
So I'll piggyback on this. I think the important part is that event you just mentioned, and something we're doing as chamber. Somebody brought something to me. So UNO has hosted, their economic development has hosted what's called an economic development outlook and real estate seminar. It's a seminar series. It's four sessions. I know Dr. Ortling's on one panel, along with parish presidents. So essentially, they've hosted UNO for over 30 years, North Shore 8 or 9 years. It came to St. Charles, got forwarded to me at the chamber, and said, hey, would you be interested? I said, yeah, only if you do it for parishes, and if you do it every year, right? So we do an inaugural this year. We're doing it at the LPAC October 22nd, so it's out for registration, but there's also a CE component for real estate agents, brokers, CPAs, whatnot. So we have a good lineup that'll be coming out here any day now. But I know Dr. O's on a panel of parish presidents. We've got several others from the area, but the whole goal behind it is, these are the ones that sell property in the area. So you talk about people that want to highlight public school systems, right? They're it, you know.
We have that gifted conference coming up too.
We do, yep.
So
Yep,
it's
it
another
includes.
exposure.
I'm realizing I wish I had incorporated some of these other events on the slide so that y'all could see that. I'll be sure to get y'all a list of those other events coming up. I think that's so equally as important as all the programming we do, is bringing people into this space.
Oh, yeah.
I'm excited. Seeing good things.
Yeah, those events, I think, just get people in the doors that otherwise wouldn't see the Performing Arts Center. And I know the town hall, there were some people there that that's the first time that they had been in the Performing Arts Center. So
And they will have a table, they're gonna have a table set up. Yeah. So they'll have a table set up and what, so I mean, it's just trying to create opportunities around that area for them, for people who wouldn't otherwise step in the role. And we've got several people from outside the parish that are registered so far, you know, so it's gonna be interesting. But if there's no other questions, we'll just need a motion to go out to go to lunch and then come back, just to pause the meeting.
I move that we pause the meeting.
All right.
For lunch.
Pause.
Thank you.